Dear friends, greetings from Foxy. I welcome you to this program of Eagle Project. Eagle stands for Every Aspiring Gynecologist Learns Endoscopy. The aim of this program is to give postgraduates an insight into the world of endoscopy so that at least some of you take interest and decide to pursue endoscopy as a sub-specialty. Today, we'll show you some basic endoscopy procedures along with some simulation. I hope you enjoy the program and I can congratulate Dr. Sejal Nayak, Chairperson Endoscopy Committee of Foxy, and Dr. Subhash Malia, the national convener for this program, for taking this to far corners of the country. Just for the sake of history, the Eagle project started in the year 2019 as an IAG project, and in 2025 this was taken up by the leadership of Foxy and IAG to take forward as a joint event. More than 125 colleges were reached in the last year, and we hope that you are benefited from this program. Thank you.
A big congratulations to you all for conducting the Eagle workshop today in your hospital. Eagle project is the brainchild of our past Foxy and IAG president, Dr. Sunita Tandulwadkar. The idea is to expose every gynecologist to gynec endoscopy, both laparoscopy and hysteroscopy. I thank all the coordinators, conveners, heads of department and everybody in the department for their contribution towards the success of the Eagle project. I am convinced that all postgraduate students and all eager gynecologists will benefit largely from this unique program.
As a national convener of this Eagle project, we welcome you all and we are so grateful to each one of you for your contribution towards the success of this project. It is for postgraduate students and the new young minds. We appreciate your time and dedication for this academic project. We are very sure with collaborative efforts of each one of you, especially the coordinators of Eagle projects, head of the departments and each companies who are supporting us, we can soar very high in the sky. This will leave the long-lasting impact on young minds and we hope they pursue their career into this endoscopy. So once again,
Hello, check 1 2 3. Hello, check 1 2 3. Check it.
Madam,
Okay. Jayashree?
I said okay, sir.
Jayashree?
He said okay.
Check.
Go ahead. Stab incision for varies to enter.
ఫొటోస్ తీసుకోండి చేయని బట్ ఫోటో తీసుకోండి ఉన్నారు అధికారులు
Yeah, so it will come somewhere in between umbilicus and zipisternum. Right?
వినిపిస్తున్నా ఏదో చెడు కొంచెం
నాకు ఒక గ్లవ్ ఇవ్వండి 7 నంబర్ గ్లవ్ ఇవ్వండి నువ్వు నీచే ఆగు.
అన్న వినిపిస్తుందా చెక్ చేస్తారా అన్న చెక్ హలో హలో
7 నంబర్ గ్లవ్
మధు అదే కదా హలో హలో ఈజ్ ఇట్ ఆడిబుల్ హలో హలో ఈజ్ ఇట్ ఆడిబుల్ సో గుడ్ మార్నింగ్ sir ma'am so today workshop Sunday we are 31st so we are starting our workshop laparoscopic workshop so Dr. Juhul sir is here and Dr. Ankursha sir
Yeah, వాపస్ Go ahead again. Now
So
you
this is
alone.
a case of
Okay.
50-year-old
Not like this.
with
Now
fibroid of.
we will be starting from scratch. So Poonam, ma'am, come this side.
I'll tell the
Okay.
case about the
Now
case.
don't in OT don't speak anyone. Okay. Now coming to this thing. Okay. Yesterday, as I told, I'll be repeating in 5 minutes. Okay. So this is blunt. When you are pushing, this blunt end will go inside, sharp end will come out. When there is no obstruction through the tip, automatically this blunt end will come out. Okay. You are only your own assistant.
Sir,
Okay.
I'll
No
tell
one.
about the case, sir.
I'm sorry?
I'll tell about the case.
You go ahead.
Uh,
Okay.
sir,
so
this-
lifting will be
Because we're also having audio, sir.
Ah.
It's recording.
So,
1 second.
1 second. So lifting will be not here, not towards you, and not like this. Okay. Put your thumb here, rest of the fingers here, like this. You only. Go ahead. Lift. Yeah. Keep it like that.
This is a case of
Now
50
going
year,
will be perpendicular.
This is a case of 50-year-old. So case of total laparoscopic hysterectomy.
Okay. Push.
She is a case of AUBL.
Push.
So fibroid, intramural
Lift it
fibroid of
above.
around 5 into 4
Just
centimeters.
lift
Another
it
small
here.
intramural fibroid they have
Push.
given 3 into 2 centimeters. So we are proceeding with the total laparoscopic hysterectomy. And after completion of hysterectomy, we'll ask
Little
her
bit
to
lift,
show some
lift,
space.
Lift.
Thank you.
Yes, you lift. Don't lift. Lift and push little bit 1 centimeter. See, it is freely going. That means there is no obstruction to the tip. Okay, now leave it. Now to check whether she is in or not, there are 3 techniques as I told yesterday. Okay, first is hanging drop method. Put a drop of saline over this because of the negative intra-abdominal pressure. If it goes inside, that means she is in. Okay, another take 2 saline syringe, pull. Some bubbles are coming, push, freely going. That means you are in. Fastest way is you have a machine here. Okay, just connect the machine. Okay, so after connecting the machine, see the actual pressure, first pressure. A machine on chandi pa. Insufflator on chandi. Okay, see it is showing you single digit. Sir is showing you that single digit. Okay, that means that there is no obstruction to the tip of the varus and gas is freely flowing. Right? Go ahead. Okay, now for the people who are new to put the port, there is the port 10 mm. Yeah, all of you remember thenar eminence is your pressing point. Thenar eminence, pressing point. Put your index finger here, grab it firmly. Okay, see thenar eminence, put the index finger here, grab it firmly. While going inside, you should be screwing more. This is screwing. Okay, screwing more and pushing constantly and not the vice versa. That is pushing like hell and screwing like this. Okay, remember, see, this has a triangular blade. 1, 2, 3. This triangular blade will cut only when you screw. Actually, there is no role of pushing. Okay, so there should be constant pushing. Screwing should be faster. Okay.
Sir, while we're inserting varus needle, if accidentally it goes and touches bowel or
Yeah, so
what is-
yesterday as I covered the topic, see, varus bore is so small. Varus bore is so small. So even if you, what are the structures you are worried of when you are piercing at this level? Okay, first structure you will be, if you are careless, you will be puncturing, will be transverse colon. Okay, more careless, some other bowel loops. More careless, direct aorta. Okay, if you puncture all these structures, all the bowel loops, let's say, large bowel, small bowel, with varus, it is going to be a pinpoint puncture. Okay, for that, nothing is required. Just keep a patient NBM for 48 hours, automatically that pinpoint puncture is going to get sealed. Okay, aorta, obviously, torrentially, it will ooze at start. Okay, but it will form hematoma, and because of peritoneum overlying, okay, it will act like a tamponade, and that also stops. That also we have seen. Okay, but this is with varus. But let's say you are going direct with trocar, and if you pierce all the structures with trocar, then there is less time to save yourself and patient both. Okay, so safety first. So that's why varus first. Okay. Bhuna madam is back. Asking the good. Today you can. Okay, 1 centimeter. You are resident, right? So remember, we are using. You should remember the number of blade. Okay, to ask to the sister which number you want. Okay, so this is 11 number blade. See, 11 number blade has cutting edge only on one side. This side. Okay, this side there is no cutting. Okay, so when you are cutting with 11 number blade, you should cut in front of you. Okay, in front of you. When you cut in front, you will be seeing how much you are cutting. Okay, when you are cutting like this, you won't be able to see how much you are cutting. Okay, the whole purpose of laparoscopy is cut. Right? Go ahead. So, how the cutting should be? Give skin traction. Okay, and only skin cutting. Only skin. No deep bites. Inka.
Sir, in your experience, did you face any complications, sir, with varus or trocar?
Ask.
With varus or trocar, did you face any complications, sir, in your experience?
See, everyone must have punctured. Everyone has. Okay, we should not tell, but everyone had complications.
Yeah.
But in last 5 years, no. Okay, hold it. Now again. Okay, you're getting pressure in this. Enough. Now hold this. Now this is not for lifting, like how you were placing in berries. Okay, this is to support your left hand. When your left hand is supported, you will get pressure in your right hand. Okay, go ahead. Incision కొంచెం పెట్టేదాన్ని. થોડું કરવાનું. એને તકલીફ થશે. Go ahead. Okay, keep screwing and push inside. Faster, screwing faster. And push constantly inside. Go, go, go. Don't be afraid. Go, 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 go. Go, 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 go. Push, push. You felt it? Okay, 1 second. Yeah. నాకు ఇవ్వండి.
Why this channel should be open in the primary because reason that once you enter the abdomen, the release of gas tells you inside the abdomen.
So after
Release
putting
control.
cannula, main port, so if gas is coming outside, we are sure that we are inside the abdomen. Like, is it compulsory, sir? Like anesthesia, we have some doubts, sir. Like capnometer regarding carbon dioxide usage.
Ma'am.
So how many liters? Is there any?
CO2 volume wise you are telling,
yes,
pressure
sir.
wise you are telling.
Volume
Can you
wise.
just rotate this?
Volume and pressure both.
See, volume wise, so there is 1 meter there. You can see the last column, that is 21 liters. Okay, madam.
Sir.
Okay, so you can see that last one, that is 21 liters. Okay, but when coming to whether it has gone inside patient's bloodstream, we don't know.
Okay.
Okay, so what it shows is it's just how much machine has pumped. It doesn't show how much it has gone inside patient's headloma. It doesn't show how much it has gone inside patient. Okay, it doesn't show how much it is remaining in the cylinder. It just shows how much machine has pumped. Okay, so coming to how much CO2 absorption, that no one can tell until unless they do the
Capno.
Okay, but whether it is needed, no, it is not needed. Okay, acute sense, yeah, pressure is more important. Okay, because the more the pressure, more compression it will create on diaphragm. అవుతుంది go 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 do sir, go 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 continuous sir, continuous go 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 sir, go left and left, right up sir, right up, ఇంకా కొంచెం ఇంకా సార్, more little bit more. Okay sir, table height full down sir. Height sir. I think last sir.
Height or down, sir?
Height, if you can, for her it will be easy. Sir, no, it is going up, sir. Down. Go. What's your name? Aishwarya. Okay. So Aishwarya, this hysterectomy, as I told yesterday, hysterectomy is simplest of all gynec procedures. It is level 1 because it is destruction. For hysterectomy, 2 ports are enough. At the level of umbilicus, making an obtuse angle with your camera port. So 1 port will come here, 1 port will come here. Go ahead. Okay, umbilicus. So 1 port here. Don't injure yourself. So never put your finger in front of your नीचे पकड़ चल fast. Okay, so perpendicular. Okay, stabilize. Okay, now hold the port. So this will give you confidence when you are holding the port. Go ahead. All other PGs focus here. Okay, this thing again and again I won't repeat when you are coming for the next case. Starts, keeps growing. Thin arm, index finger here. Yes. Slightly lean. Come behind little bit. Yeah. Okay. Always make yourself more comfortable. One second. It is here. Yeah. Come. Push. Yeah. Very nice. Aishwarya is final year, huh? तू डाल के दे दिखाओ सावलम okay అక్కడే ఉంచుకోండి yeah so now coming to Aishwarya, you are right-handed, left-handed? Right-handed. Okay, so remember, because she is right-handed, she is dominated on her right hand side, so she should always operate her dominating side first, that is the right side. So we will be starting with right side of the uterus first. Now whichever side you are going to operate, remember your sealing device, whatever you are using, ligashore, harmonic, shearer, bipolar, whatever you are using, your sealing device should come from the same side. Okay, so we are going to operate the right side of the uterus, so your sealing device will come from here. Okay, for traction in hysterectomy we use myoma, so take myoma. See, and what's your name, this lady? Anjana, I'll be telling you your hand movements. Okay, hand movements. Hand towards her, okay, means surgeon. Towards me means towards here. Hand opposite side. Hand down means hand down. Okay, so never tell your assistant movement of uterus. Are antivert chahira, retrovert chahira. No. Okay, no antiversion, no medical terms. Always explain it to them in their terms. So hand up, hand down, they will understand. They'll easily reciprocate. Okay, so keep your hand that side. Okay, in entire process, there is no pushing of this thing. Okay, they should just stay inside the uterus. In entire process, you will be pushing this. Okay, and no pushing here. Okay, stable now. Okay, now you will going to enter with myoma in her left hand. Go. Yeah. Okay, how to put the myoma and where to put the myoma? It is always here. There is some disformity, right? Now, but it comes always closer to the right cornua. Okay, because we are going to operate the right side of the uterus, so right cornua. Relax. There is no need for force and all. It is only how to put a myoma. Go there, create a depression. Okay, just start screwing. screwing, and make the uterine surface perpendicular to your myoma. Okay, so it should not go like this. If it goes like this, it goes tangential. Okay, so always perpendicular. Yeah, keep screwing. Only 2 fingers are enough. 2 fingers. Yeah. Okay, take shearer. You have done with the shearer, no? So you do it with harmonic.
But we don't use harmonics.
So you want to do it with shearer.
Even hotel also will routine only.
Sorry?
Don't want to try new one.
No, हार्मोनिक तू नीचे रहे, इधर जरूरत नहीं है. मैडम रहते क्या? हाँ ठीक है. माँ, ఇది 7 mm washer, 5 mm washer.
ఇది వద్దు సిస్టర్, పక్కన పెట్టండి. అది పక్కన పెట్టండి, జాగ్రత్త. ఇది కూడా పక్కన పెట్టండి. ఇది పక్కన పెట్టండి. హార్మోనిక్ కదా ఇది.
You can feel this, feel it once. Is it tight? You can feel it is tight.
No.
Yeah. Why? Because yesterday I told you didn't pay attention. Skin here, rectus sheath here, peritoneum. Yes. So you have traveled inside abdominal wall. So this has become fixed in this direction only. Now to put the instrument, I have to want to do this. Okay. Now see how much traction I need to give. Right. So to do that, all 3 things should be in the parallel thing. So ideally you were supposed to come here. See, but where you came? There, because that's why that got fixed. Okay, now feel. Okay, still it is. Hey, I also can be wrong. You can tell. Okay, okay, go ahead.
So the port should be perpendicular to the abdominal wall.
Yeah.
All 3 layers.
All 3 layers should be pierced parallel.
Parallel.
Okay. Remove this. Hold it like this. From here. Like this. Okay. It is only opening, closing, kada. That is required. Don't hold that. Put your hand here. Okay. Now remember, as I told you yesterday, now this is hysterectomy. So if all 3 structures are coming together, okay, don't worry about that fibroid. Fibroid is separate. Okay. Now all 3 structures, if it is coming together, we will go and take it. थोड़ा ये tilt करना. थोडं tilt करावं. અને આખી ટ્રોલી આ બાજુ લે થોડી. સિલિન્ડર જોઈને. You are pushing below. ચલો. Hold. Okay. No crushing. Hold means just relax. Just hold it. Okay. Now do you drive car? You're married? Oh, I was about to tell whether husband allows. Okay, so why did I ask you that is because even if you drive car, you don't look for clutch and accelerator again and again. You continuously look in front, right? So that's the same thing here. Now you know that you are going to use bipolar. Okay, so bipolar only first 2 buttons you are going to use. Matlad kandima. Okay, so you are going to use only these 2 buttons, first button and second button. First button for seal, second button for cut. Okay, so without even looking, keep your foot rested in between these 2 on the floor, not on the paddle. Okay, on the floor. Okay, so without even looking down, I know that my left side is seal, right side is cut. Okay, maybe in your initial cases, you might have to look down. Okay, but don't make it a habit. Okay, now what we intend to do, seal. So fire seal. Fire. Continuously you will fire at one location till bubbles stop. Bubbles stop, you stop. Okay, open. Then one shot laterally. Okay, you have done open hysterectomies. So in open hysterectomies, do you do like that? You put one knot this side, one knot that side. Okay, enough. So it has given you a beep sound. Okay, so for first shot you gave it here, one shot you gave it here, then one shot medially. Okay, hold it. Okay, No bubbles. Stop firing. Now recheck all three levels, whether it is bubble free or not. Yeah, go ahead. Okay. Okay. Central. Yes. Okay. Medial. This is the last time I am repeating the hysterectomy steps. Huh? So call all the residents and whoever is going to operate. Okay. Enough. Okay. So all three levels you have checked now. Now it is time for cut. Now cutting. I'll tell you the cycle. So all of you pay attention here. Now coming to zoom case. This is scissor. This is scissor. Focus. Okay, this is scissor. Now how you cut with this scissor? How you cut? You take little amount of tissue. This is normal scissor. We call it like the cold scissor. Cold scissor. How we cut with this instrument? We just take little amount of chunk. Okay, we completely close the scissor. That's how scissor cuts. Okay, that is also scissor. Okay, but that is hot scissor. Okay, so you have to do the similar action of closing like this. You have to do similar action but with current. Understood? So the cycle would be, I'll take that instrument, I'll keep the instrument this much open, not this much open. Same like scissor, this much open. I'll take little amount of tissue chunk. Okay, I'll activate the cut current. With continuous activation, I'll simply close the instrument. I call it like a scissoring action. Okay, the same theory, now practical. Now, as I told you in sealing, okay, two rules. Sealing time, first hold maximum. Okay, so what she achieved sealed. Okay, so sealing time, you will go and hold maximum like this. Okay, and now you must have heard your professors telling you when you are doing open surgery, okay, don't fight with the tissue or tissue will fight back. What do they mean by that? Okay, if I am holding like this and I want to achieve a seal, okay, then to achieve a seal, if I pull like this is traction. Okay, if I push like this is traction. Okay, if I crush between two blades like this, that is also traction. Okay, this all will cause inadequate sealing. Okay, so sealing time, two rules. Rule number one, hold maximum. Rule number two, that tissue should not be under traction. Right? Now you have already done sealing. Now cutting time. Cutting time, tissue should be under traction. So you will bring it under traction. Exact opposite. Okay. Second, in sealing, you will hold maximum. Whereas here, you will cut minimum, millimeter by millimeter. Okay. Or you will try to do by the tip of the instrument. Okay. Go ahead. So the theory, as I told, you are pushing. Anjana. Yeah. So she reached there, hand aside ki ma'am. Okay, activation, come closer. This patient closer. Yeah, comfortable?
Yes.
Okay, so you reach there. Yeah, now you will keep the instrument open like a scissor. Okay, 1 second, I'll focus for you. Okay. Now she has kept the instrument open like scissor, as I've demonstrated. Open like scissor. Now activate the middle button, cut current. Okay, we will act continuous. And she will just close. See, one more time. Activate and just close. One more time. Activate and close. Okay. Do it. Because of that fibroid, vision will be obscured, but okay. Go ahead. Close. What button you are pressing? Center button? Cut, no? Okay. So now this was step number 1. Step number 1 is to take the adnexa out. Okay. Step number 2 is to broad ligament now. Okay. So broad ligament. I'll be okay. She wants to hold, but below that those people won't be able to see. Understood? Okay. If she doesn't go, okay, come. Come, hold. Okay, now she has reached to, keep it steady. Okay, what's your name? Deepa. Sorry, sorry. Is it okay now? 2 minutes. Okay, now step number two. Step number two, to take out the broad ligament. To take out the broad ligament, remember, maintain 2-3 centimeter distance away from the uterus. Okay, not close to the uterus. 2-3 centimeters away from the uterus. Keep on chopping both the leaves of broad ligament together till you reach isthmus. Okay, so first create traction, push the colpotomizer and maintain 2-3. Create, ma'am, push colpotomizer and hand up. Hand down, ma'am, little bit. Keep it like that. Stable. Push the colpotomizer. करना तेरे को बोला ना मैंने. रुक जा अभी. Okay. Now both the leaves. Okay. Maintaining 2-3 centimeter distance away. So she'll be cutting here. Okay. Chop it. Scissoring action. Okay. You'll keep the instrument open. Activate. And close. Close completely. Stop. 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 Okay, again create traction, okay. Now go, just keep both the prongs open like this. Okay, activate and close fast. Close. ये मेरे को ये कर peroxide दे. Okay, yeah, second, seal it now. Enough. Okay, now step number 2 is over. She has reached till the level of isthmus. She cut both the leaves of broad ligament. Okay, now you have reached isthmus, right? What is isthmus? Hand up, ma'am. Hand up. Correct. Correct. Okay. So what we will be cutting? Where is isthmus? Isthmus is where upper segment is ending. Okay. Here, somewhere here. Okay. You can see this. 1 second. Give it to me. You can see this faint. No. Go that side. Leave it. देना दूसरा दे तो साफ कर पुल जल्दी भिगो के दे पेरोक्साइड सावलॉन में डुबो दे दोबारा okay. Okay, so create traction. Yeah. Okay, push madam ఇదేంటి ఇది one second. ఇక్కడ కూడా ఒకటి ఫైబ్రాయిడ్ ఉంది is also fibroid. Where is your center rod? Okay, bring little bit in center, ma'am. Where is your center rod, ma'am? మొత్తం బయటికి వచ్చిందా पुश कर वो सेंटर रॉड अंदर डाल. क्या कर रहा है? हाँ, don't push the center rod. Align it in cavity. Push. Okay. Push the colpotomizer and that side. Push the center rod, ma'am. Center rod is not inside. करना. अंदर है. हाँ, हाथ ये बाजू कर. हाँ. Okay. Push the colpotomizer. Okay. Now coming to this thing separation. Okay. UV fold. Okay. So you can see this fade. Hand up, ma. Hand up. Hold it. Okay. Okay. Come. Just you keep it like this. You give it this thing to me. Okay. Now we have reached at the level of isthmus, right? So isthmus, you can see this faint, very faint white line, or forget about white line, where this peritoneum is coming and getting gathered somewhere here. Okay. So in fear of bladder, don't be very close to this point of adhesion. Okay. Maintain 2-3 centimeter distance away from this point of adhesion. So your cut will come somewhere here. Okay. Go chop it off. Direct cut, cut, cut. Don't look down and again and again. Cut. Close. Go. Close. Don't come above. Go below. Go ahead. Cut. Yeah. Okay. With this, we will see that. Open. Open. Chop it. We chop it. Yeah. Okay. I am able to see some fat. So I want to push the fat with bladder. Push, madam. Colpotomizer, push. And where is your center rod? Abba. Hey, tu बैठ जा. ఒక్క నిమిషం. సెంటర్ రాడ్ ఓన్లీ బై ఇదే ఏంటిరా, ఇదే సెంటర్ రాడ్ కదా, ఇక్కడే ఉంది కదా సెంటర్ రాడ్. पुट दे. ये इतना बड़ा क्यों लिया है पहली बार? था ना उनके पास दूसरा है, वो है ना वो. Relax. That you relax. Take it out. Take that sims out. Pagad. Okay. So this here, this here. Don't retract this. This should stay inside uterus. Okay. Hand aside maximum and push the colpotomizer. Array, 1 second, fibroid is. center rod push handle open. Push ante just keep it inside uterus. Okay, just come on, hold. Okay, so now this you can feel this little bit, there is some elevation that area. Okay, so that is, just imagine that is our colpotomizer. Okay, now we will go ahead and chop, close, stop. One second, close the instrument, close the instrument. Okay, open. Normally it won't be like this. Chop it. It is degenerated. Close the instrument. You can feel this is bladder. This is bladder. Okay, so what we are trying to do, we are just trying to push the bladder to go below to the level of my colpotomizer. Okay, this is because of degeneration. Normally it won't be like that. Okay. Okay, so we will go open this. Hand down cheyandi koncham. Hand down, inka down. Push. Enough. Chop it. Stop. Relax. Holding wise, relax. Okay. Hold. Close the instrument. Okay. So this is okay. This is not going freely. Hand up, ma'am. Koncham. Bus. Keep it like. Okay. I can see there is no bladder, but. Okay. Now enough. In this case, I am not able to, because this area is very much degenerated. Okay, so but our bladder, just open it. Whenever you have doubt, just hold the UV fold. Hold it, and lift it. See, you can see my bladder is below. Okay, so open. Now I can go and take care of my uterine. So hand down, keep it like that. Don't move. Hand maximum east side. Keep it like that. Okay. Now next step is to take uterines. Okay. So go ahead. First shot will be given at the level of isthmus. Okay. So where is isthmus? Where this segment is ending. So there you will go completely. Okay. And hold it. Hold first. Hold first. Hold first. Hold. No crushing. Just simply hold. Okay. Fire. Enough. Okay, no bubbles, no firing. Open. Then you will move lateral. Go ahead. Hold first. Enough. You are crushing it. See, you have cut it here. Cut it now. Close the instrument. Don't do anything. Push the colpotomizer. Open. Hold. Relax. Okay, no need for that much force. Hold it in your way. Hold it in your way. How you were holding, like that. Okay. Go ahead. Hold. Relax. No pulling it down. No crushing. That is your uterine. Fire. Okay. No bubbles are coming. Stop. Fire. Enough. Okay. Stop. Fire. No. That becomes scissoring action. Always when you want to seal, means go hold first. Then you fire. Push. Close the instrument. We will send little. We'll have to send a little bit of ladder below. cervix was healthy, no?
हाँ,
Push.
sir.
तू इधर खड़ा रहे ना, irritate मार रहा. No, no, you sit there. तू इधर ही खड़ा रहे. Okay, so this is our colpotomizer. Because of the degeneration, no, that bladder has slightly other. Okay, chalo. So first shot you gave it here. Okay, then you moved here. This is my colpotomizer. 1 second. Just press that bipolar when I tell you. Fire. Fire. Come. Hand down. So you, and this will be our last shot at the level of colpo. Hold it first. Not like that. Relax. Instrument, no extra traction on the tissue. Hold. Okay. Fire. Enough. Enough. Hold. Fire. Okay. Okay. Now cut in between. Go ahead. Now you saw the lumen. This is the lumen. Okay. So which tissue is holding the lumen? This tissue. Chop it off. Yeah. Now this is the lumen. Which tissue is holding the lumen? This tissue. Yeah. Chop it off. Yeah. Now push. हाथ ऊपर कर थोड़ा. Now you are able to see the colpotomizer. Close the instrument. See, it is badly. Okay, that part we will take care. Open. This tissue. Chop it off. Chop it off. Instrument should stay there only. If you do try to do forceful thing, then only it will jump off. This entire thumb you don't put. Try to do with the distal phalanx. Right. Okay. Go ahead. So how to cut? You will just, no need to keep it like this. You reach there. Okay. Now activate. And not that. Do you cut with scissor? Do you close the scissor like this, chuck? No. You close it casually, like that. So here also the same funda. We have positioned the scissor. Now activate, and I want you to close that slow. Go ahead. Close. Little bit faster now. Okay. So now this is my uterine. See, this is my uterine. This is my colpotomy area. So when I'm going to do my colpotomy, my uterine is not going to come in my way. That is the end of that cell. Okay. Just chop off little bit of uterosacral and we are done. Support, reach there, support both the prongs. I want to cut this. So reach there. Okay. Now activate and close. Okay. So my colpotomy area is free. Right? Done. Sure. Oh, come. Nice one. Aishwarya, no? Good. Come. Clean. Yeah. Take that out. Unscrew. Yeah. Take it out. Yeah. Keep it like that. Wait. Okay. All the instrument, all the sharp instruments, or what's your name? Yalini. How I'll remember 140 PG names, man. Anyway, some predominant ones I'll remember. Who is going to operate with me? Plain gauze.
Camera, sir. With your hand, we'll hold your camera.
Come. 1 second, I'll see. Savlon.
Sir, వెనక చూసి
Anjana, hand that side. Hand down. Okay, whatever. See, don't imagine like anything, any big camera. Imagine like a mobile camera and you are married, no, ma'am?
Yes.
Just imagine that you are taking a photograph of your husband. Okay, husband is standing there. And if you keep a photo here, what is the point? Okay, so idea is just imagine that you are holding a mobile camera. Okay, and whatever she is doing, keep it in the center. If she is doing here at Nexa, if you keep it like this, that's how if you take husband's photo, then it is gone. Okay, so keep it in center like this. Whatever she is doing, that's all. This is separate thing. That I'll teach you later. For time being, just imagine that this is mobile camera. That's all. Okay, go ahead. Now you are operating the left side. Ma'am, tilt correct chestanu, ma'am. Tilt, ma'am. Supine, make it supine.
Sir, like this uterus with fibroids. So if they are not disturbing your vision, so usually what you will do? So you proceed with hysterectomy, or you will remove them, or you will proceed, sir. With for example,
if no one is disturbing you, why you want to disturb them?
Okay.
Correct. No, it is not disturbing us. So
Yes.
why to disturb it?
So no need to remove.
Anyway,
For
we are
example,
removing uterus. It will come out.
For example, it is in broad ligament. So you're not able to broad ligament fibroids. You will remove.
Anything which obscures your vision and anything which is important for you to do the hysterectomy, okay, that you need to remove it before. Okay, so always what you want to ask, I understood. Okay, whenever anatomy is distorted, so your first step is, okay, restore the anatomy.
Okay.
Okay, here anatomy is not distorted, uterus is distorted.
Yes.
So where anatomy is distorted, restore the anatomy, then proceed with the case.
Okay.
And not like whatever is available, let me do that first.
Okay.
Arey, adnexa convention, let the adnexa be out. Then I'll think about the artery and all. Not like that. First, restore entire anatomy.
Okay.
Okay. Hand down. Okay. Hold myoma. Come from right. Okay, now she is entering. Okay, so as a cameraman, you should be more vigilant than surgeon himself. Okay, so when she is entering, she is coming out, she is coming with electrical instrument. You should be vigilant. Okay, now go inside, show it to her. Now you know that where to come. This is my left cornua, right? So this will come here. Okay, closer to my left cornua. How to place a myoma, as I taught. Create a depression. After that, only screwing. Keep screwing. Keep screwing. Make the uterine surface. Hand thoda upar, hand up ma koncham. Let the fibroid get rotated. Center rod bite ke tesara inka. Okay, go ahead. Start screwing. Don't hold. Sister, ide hold patkondi. Ide chai patkondi. Go ahead. Okay, so make the uterine surface perpendicular to your myoma. Keep screwing.
So while doing tailor chin laparoscopy, so camera and traction from below, both are very important, no, sir?
So, good question, ma'am. See, manipulator will give you very good traction in the lower segment. Okay, in the colpotomy side. Okay, in the center rod and hand maximum E side. Okay, now once you have kept it, keep it stable. Now take the instrument in your right hand. Buna ma'am, ikkadiki vasta. I have to go that side. Center rod, hand koncham up cheyra neeku. Time pass చేస్తున్నాం. Okay, keep it like that. Go ahead, you go closer. If your husband is there, will you keep it like this? Like this far? Little bit closer. No, the more closer you are, more confidence she'll get. Okay. Okay, hold it. Okay, no crushing, not creating traction, no pulling, pushing. Okay, just hold. Close. Inka. Hold. Hold. Okay, fire. Sister, koncham aa side ki వెళ్ళండి. ఒక్క నిమిషం వెళ్తా ఆ సైడ్కి వెళ్తా. Go ahead, fire, keep firing. 3 levels, as I told. Central, medial, lateral.
Central, medial, lateral.
Okay? Go. Okay, bubbles are your sign. Bubbles stop, that means sealing is complete. Okay, go ahead. Good. Go ahead. One hand is also more than enough. You are holding two hands, how it will be? Okay, okay, enough. Okay, so you gave one shot here, one shot there. Okay, so I want you to give shots like
Sir, till bubble stops, we
like
have to
this.
stop, or till
Okay,
the
hold.
machine makes kick sound,
Sorry,
we have
ma'am.
to stop, sir. Till bubble stop, we have to stop.
Bubble
Or
stop,
we have to
that
wait.
means there is no water content in the tissue.
Yes.
So blood also, what is water content? Okay, when this is the tissue and I am holding the tissue like this, okay, when I am giving current, the current will get converted into heat energy here, right? Because of the heat, the water content of the tissue, that means intracellular water, extracellular water, blood in the capillaries, lymph, this entire water content will start boiling up. Once it reaches to 100 degrees Celsius, then it will start vaporizing. Those vapors will be grossly visible like bubbles. Okay, once the bubbles stop, that means the water content of the tissue what you are holding, it is zero now. After that, whatever current you are going to give it to the tissue, it will burn the tissue mass. Eventually, it will char the tissue. Okay, and what is the practical important point about the charred tissue? Is charred tissue is a bad conductor of electricity. Okay, so if you make the tissue charred, your instrument won't work. Okay, so bubble stop, you stop. Go ahead. Fire, seal, enough. No crushing. Okay, remember, cut this. దగ్గరికి scissoring action. Scissoring action means keep the instrument open, activate the cut current and close. Okay. 1 second. Hold it like this. You come closer. Keep it like this, or the people who are sitting in auditorium, no, they'll start calling Boona madam. Madam, now it is not visible also. Okay, so you have given a cut. Have you reached to isthmus? No. So we will be cutting more. Okay, chop it off. Go closer, madam. Enough. Chop it off. No. So first of all, give her some space, ma'am. Give her some space. Make yourself comfortable. You go come this side. Okay, this will be your left foot only. Okay, and don't rest your foot on the pedal. Okay, on the floor. Okay, now see there, look there, make yourself comfortable. It is simple, only one instrument. Hold it like a pistol. Okay, you should be having the more control. There is nothing inside. I just want to chop it. Hold it relaxedly. This much force is not required. Okay, we reach there. Okay, just activate and close. See, go ahead. Yeah, right. Push the colpotomizer. Okay, so that side of bladder dissection. No pushing like that. Okay, close the instrument first. Close the instrument first. Push the colpotomizer. No pushing like that. It is visible like that, but you should be very gentle.
So with closed instrument, we have to push, sir, all the fat below colpotomy.
Closed instrument. Open it. Don't push that. Okay. Okay, so this is little bladder. Leave it, ma'am. Only capillaries. No, you yourself is telling those capillaries. Okay, only capillaries. You can leave it. If it is making your, again, if it is making your vision obscured, you have to take it. If it is not hampering your vision, then you leave it. Don't hold this mark. There is no need for holding. Okay, this, when you hold, uterus will get punctured. This has gone inside uterus. Pushing will be this only, and this much pushing also not required. One thumb is enough. Okay, this you are not pushing, that's why he has to help you. But one thumb. Okay, when you push more than your body gives, you will get tremors. Till that time, you won't get. Okay, you are getting tremors, that means you are pushing more than your body has. Okay, hand down. Enough. Okay, hand down. And you, chalo, go ahead. Now, uterines go inside. So that side, how she took everything together. This side, I'll just show another way. Take out the posterior, chop it off. Chop it off, scissoring action. Keeping the instrument open. Keeping the instrument open, not that much. Okay, only peritoneum, don't activate. Hand down, ma. Close it, no, little bit. That's all. Chop it. Chop it, go closer. Okay, so now she has reached, this is the posterior cut what we give, okay, but till you reach uterosacral. So she has given cut from here to uterosacral. Now take care of uterines. 1 second. Okay, chalo. Now uterines. First shot at the level of isthmus. Okay, hold it. Hold it. I don't know, the whole chain continues. Go ahead. Fire, fire, fire. Chinta pani se kya?
కింద కొంచెం ఎస్ చెయ్యి కంటిన్యూస్గా అలా ఆపుతుంది యూఆర్ స్టాపింగ్ ఎందుకలా ఆపుతుంది చెయ్యి పట్టుకోండి చెయ్యమ్మా
अरे हाँ मेरे घर पे जाना
స్టాప్ నెక్స్ట్ పైకి 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 నాట్ చెయ్యి చెయ్యి
Okay, so you have started from here. Okay, your final shot will come here. Hold it, hold it. You push the colpotomizer. Fire. Here also you cut. Enough. Okay, you have cut. So hold it. Cut it. Cut this.
Sir, in foot pedal, she's not using cut option. But why is getting cut, sir?
Because she's crushing it. You understand? When tissue comes under traction, whatever type of current you give, even if she is giving seal current, she wants to have, she has an intention of sealing, but she is crushing there. What will happen with current? Because this has triangular blade. See this. Okay, current is concentrated in one line. Okay, now when you crush accidentally any point of time, it will get cut. Whatever, even if you are giving seal current, but if you crush, it will get cut. Okay, so never crush. Only sealing time, just go and hold the tissue. Hold. This is holding. Okay, more than that, that is crushing. Go ahead.
So we have to handle the tissue very gently.
Good. Again, she cut. Okay, so okay. Just hold it, seal. That's all. Don't increase the crushing. Seal. Cameraman, woman, go closer. Hold, hold, seal. Enough. Okay. This side also one more time, or else it will spoil the vision. Hold it, seal. Okay. Now you do your favorite job, cutting. Cut here. Cut. Yeah, you saw. 1 second. Understand what you are doing, or else it will become mechanical. Okay, so this is my uterine. Okay, which tissue is holding uterine? This tissue first. Chop it off. Push ma. stable. Okay. Close the instrument. Okay, so this is one layer. Open it. Open. Go inside. You also go now. Your husband will be very much never he will give it to you to take photo of his. Okay, and you why you're pulling? See, I want to cut this, right? So open this. Imagine like don't hold. Imagine like a scissor. Let the tissue go underneath. Now you chop it. Right? Close the instrument. Whatever we have chopped, relax. Close the instrument. As if like nothing you are holding. Okay, so this is our plane. We got the plane. Okay, chop it off this one bit. Okay, but with unipolar you can come and chop. Okay.
So unipolar you only do.
Okay, so come final we will send the this is uterine, this is my colpotomy. Okay, so we will send this below, more below, because when I'm going to do my colpotomy this uterine is going to come in my way. And this side ma tu kiske liye khada rakha Shenu तेरे को? Open. Chop it. No need to do here like this. Just simple. Keep it supported. Open the prongs. Okay. Activate the cut current and close. Again. Activate the cut current and close. Enough. Okay. Chalo. Take it out. Okay. So understood till you tried. Now come this side.
Just a option.
You do. You are okay from that side?
No, I think so. I'll remove this one. I'll come here. This
Ready?
Even.
Okay, white krill, take white krill. Okay, keep cut 30 centimeter, make it ready. With the hook, push the colpotomizer. Center पे. Push, हाथ को बाजू कर थोड़ा. Convert.
Oh.
Open చేయండి. Cut it. Yeah, plastic only. So even if you, the question why you are asking whether the current hampers that.
So shall we use bipolar?
Yeah, take the bipolar.
Bipolar.
కొంచెం ప్రెస్ చేయండి. లాస్ట్ కట్ కరెంట్ ప్రెస్ చేయండి.
Coagulate. Bipolar even. Connection. Sister, bipolar sister. మీరు ఒక్కరే ఉన్నారు ఇక్కడ. సీర్ ఇక్కడ.
కట్ ప్రెస్ కర్.
Sister, bipolar even.
ఉంది. ఇక్కడే ఉంది. చేంజ్ చేయండి. This is your Descending cervical.
Cervical.
Fire. First convert the machine.
It's converted, sir. It's in bipolar only.
Okay, fire. Seal, seal, no?
It's coagulate I'm doing, sir.
First button, bipolar. Fire. हाथ नीचे शीनो. Seal. 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 बहुत ज़्यादा पुशिंग चल रहा. Fire. Hook. Hand inside, hand down. It doesn't mark. Plastic melts at least I think till my knowledge goes more than 300 degrees Celsius. This creates only you are cutting the tissue. Cutting the tissue means only 100 degrees Celsius isn't it? It doesn't. Sometimes you might get scratches and all, but it doesn't melt. Why that I am? You take that. My point is like, okay, come back, ask the same question again.
So, is there any chance to the current or energy transmit to thermal?
Yeah, everything. See, all the structure. It is the use of instrument. So if I see how she is doing with the tip of the instrument. So she is doing with the tip of the instrument. So see how much is the point of contact. If point of contact is very less, now how she is doing the unipolar fire. See, unipolar with a tip of the instrument. You're sealing. Different sound is coming. I know the machine, but the sound is fire. Yeah, so at least like any current, you will have at least 4-5 millimeters. Wait. Fire. You will have 4-5 millimeter of spread. Okay, but the thing is whether it will go how far, that depends on the point of contact. If your point of contact is minimal, lateral spread will be less. If your point of contact is very high, fire. One second. Fire.
The learning stages of
common mistakes. In every step you ask, no? Common mistake I can give you 100. Putting the trocar wise, putting berries wise, in which step you can do which mistake. That if you can ask, then I can tell. Okay. Go ahead.
Fibroid and all. If it is big fibroid, we can marcelate the tissue and then we can proceed.
After doing hysterectomy.
After doing hysterectomy, that fibroid is there. No,
means like when uterus is intact and at that time only you want to do marcellation?
We can do, sir.
Your uterine won't ooze. If circulation is still intact, if you do the marcellation, it will bleed like hell.
Okay, after uterine artery is
after hysterectomy is done, after uterine artery is taken care, then you do whatever
you want. Can do, sir. For myomectomy, for intact uterus, we cannot remove by marcellator, sir, at first.
You cannot means like, see, for morcellator to work also, you will be like shaving the fibroid if you don't remove the fibroid.
Shaving the fat. Okay.
You understand? Fibroid is sitting like this, okay, and uterus is there. Now you want to remove this. You are telling without removing the fibroid, you want to morcellate the fibroid. If you fibroid is sitting on the uterus, and when you morcellate, you will be shaving the this thing. Okay, so little bit of fibroid will remain with uterus. That you cannot shave.
Okay.
Correct, no? Imagine.
Okay. So removing it with the capsule is better.
Removing?
With the capsule intact is far better in toto.
First, remove the fibroid and then do morcellation. That is the standard way. And forget about the standard way, but that's how it should be done. निकाल निकाल tubes ovaries. Tubes ovaries. Mom, tell me, someone was mumbling.
Sir, while removing admixture, so just without knowing like there is ureter and all, we have to be sure.
Yesterday, as I told you, okay, so even if you don't want to see the ureter, you don't know what is the whereabouts of ureter, then also don't worry, just be close to the organ what you are planning to remove.
Okay.
Okay, here also I didn't see the ureter.
Yes.
I have anatomical knowledge that ureter cannot be here at any point of time. It should be here.
Okay.
Okay, but even if for newcomers, if you don't have any idea, just be close to the organ, whatever you are planning to remove. आ जाता निकालना पहले यूट्रस बाहर निकाल
Rama sister
ये इधर मार लड़की माइकी वाला
sister
क्या हुआ निकाल आ जाता निकाल गोल पूरा रोटेट फाइब्रॉइड
on suction on
suction on
switch on brother ni pilu
okay Insufflator on change. संदीप सर को बोला
నా ఇక్కడ ఇక్కడే లేడు ఉండండి చూడండి పోయింది ప్లీజ్ చెక్ కేబుల్ కనెక్షన్ కొట్టండి
अच्छा if you push more, what happens? It jumps off. When it jumps off, it will go and hit some structure. Okay, she is also giving traction from below. And when you are putting myoma, at that time, let's say uterine surface is very hard, adenomyotic, yesterday we operated, like that. Myoma won't pierce only that type of tissue. And at that time, if you are, let's say, pushing, myoma will jump off. Okay, if you are putting from here to that side, and if myoma goes and jumps off, directly you will go and hit the external island. Correct? First. Second, if I overdo things, I want to seal. Okay, initial days, you will tend to be extra, what do you say? You will tend to have extra precautions. Okay, no, I want to seal, I want to seal. In that instance, is oozing and ureter is here only. If this is oozing, to control, okay, because it will start oozing, the blood will go from here and there everywhere. Okay, now to control that, what you will be? You also will be in panicky mode. Okay, go and hold it, anywhere, go and hold it. Okay, don't do it like that. Come with the suction irrigation, irrigate. Okay, just take all the blood off. Okay, once all that blood goes off, after that you will be able to see clear cut where it is coming from. Okay, then go and identify exactly at the site of adhesion. Still, if you are not able to do, okay, there is no other option. You have to go lateral to the ureter. You have to, and leave the audience. Now I'm done. Next time. Will do. Plastered uterus. I'll open one space of red GS for you. So yesterday it was pending. क्या हो गया?
मेरे को लग रहा है ये 4K पे इन्होंने ये लगाया तो प्रॉब्लम दे रहा है.
नहीं चलता कुछ नहीं होता.
So by doing this procedure, firstly we have clamped and cut the round ligaments, and then later you took care of the ovaries, right, sir? Why can't we directly clamp the line?
Very good question, Aishwarya. She is very brilliant. Yeah, good question at the PG level. Okay, what she is asking is why we are doing adnexa together. Okay, and then we are coming back again, and then we are removing the adnexa. You understand? So while doing, before only you can remove the adnexa and like take it out with a complete specimen. No, see what happens if you do it like that. Okay, that adnexa will be keep on hanging there. Here you have a vision of this much. Okay, and the structures keep on hanging. Your cameraman will struggle. Now you had one fibroid. You understand how much struggle it was. Now you will have all three structures. They are hanging once you remove it. Okay, so only for a technical perspective we don't do, or else nothing wrong. Yesterday night you didn't sleep or what? Tak, question. Good.
That is how the participation.
So what was the most difficult case you have faced till now, sir? Which took you the longest time?
You operated.
Challenging.
You have interviewed, sir.
Or any interesting cases you would like to tell us?
Audio. So they are listening to audio. Audio is not clear.
Come. I was expecting you will come.
No, they want you to. I'll keep like this.
It is not working, I guess.
It's not. ఇంకోటి ఎక్కడ ఉందన్నా? హలో ఒకసారి ఫోన్ చేయన్నా మేడం వినిపిస్తుందండి నీ ఫోన్ చేస్తాను ఇది వాళ్ళకి ఇచ్చి ఆన్ చేయించండి ఇది వాళ్ళకి ఇచ్చి ఆన్ చేసుకొని తీసుకున్నాను హలో వినిపిస్తుంది ఓకే సరే I'll keep like this. No, they want. It's not your. It's for the athletics.
I'll come there only, sir.
No.
Ayyo.
I thought I'd keep middle.
Okay, shoot now.
Difficult case you are longest taken.
It happens, but the most challenging one was one leiomyomatosis we operated in Hyderabad. It was like around, I remember only that case. It was horrible and it was like complete inside. Okay, and splenic artery had bifurcation giving that parasitic fibro. Like the trainings are same conducted by me only. Trainer is okay. Now in Aurangabad in the 4 days we operate around like this only. This we operated around 16 days, but not like this. We will be filtering cases for you. Okay, so we will be filtering all the type of cases which will build your confidence. Something like not like this, where complete straightforward cases. Okay, so that you gain that confidence. And per fellow we give hands-on for 4 cases.
Wait. To tell this again.
Sorry.
It looks like my branding now.
I'll only tell.
Yeah, you only tell.
They are telling tick tick and they are calling not tick tick. Hello, madam. Madam, ఇప్పుడు ఓకే అంటున్నారు మేడం, మళ్ళీ చెప్తాం మేడం. మేడం ఆడియన్స్ ఫేస్ మేడం, అక్కడంటే ఫేస్ చెప్పిస్తాం మేడం. అదే మేడం, ఆడియో మళ్ళీ చెక్ చేస్తున్నాం మేడం, మళ్ళీ చెప్తున్నాం.
అక్కడ రావట్లేదు
మేడం, ఇప్పుడు అడుగుతాం మేడం.
అరే వాళ్ళ దగ్గర ఇంకా ఒక సెట్ ఉంది
సార్, అక్కడ చూసి వాళ్ళంటే చూడండి.
నిన్న కూడా సేమే అయింది
సార్. Same question, sir, don't mind. So we want to know the details of your training program, sir. So first I'll ask one question, sir.
First you ask whether audio is audible or not.
Call. So audio is audible or not?
You connect there.
Madam, is audio audible or not? Please tell us. Because same question I'm asking, sir, third time.
Right.
1 2 3 check. No. Sir, we want to. I'll ask question by one question of the other question, sir. So we want to know who are the first eligible candidates, sir, for your training program, because as post graduates they can come, or who has to come?
All MS passed. Okay, MS, DGO, anything with gynac degree. Okay, all of them are eligible. And if I know the resident also well, then like with recommendation of HOD, we take them. Okay, not or main criteria is like they should be passed. That's all. Okay. So I have 2 training programs. I'm just repeating. I have 2 training programs. One is in Aurangabad. That is like it's renamed as Chhatrapati Sambhaji Nagar. That is in Maharashtra. Okay, that is for weekend 4 days. That is Thursday, Friday, Saturday, Sunday. In these 4 days, you will be operating around 15 to 16 hysterectomies. Okay, and per fellow you will be getting like hands-on for 4 cases. Okay, it is not in one hospital, so I am tied up with at least like 10-15 hospitals there. So they pull up cases for me. Now another is in Hyderabad. Okay, that is for 7 days and 1 month. Okay, so I have a hospital in Hyderabad, if anyone is from Hyderabad, in Kukatpalli High Tech City. So okay, so there the longer courses, your accommodation will be there only. So 1 month is there, 3 months is there, and another is 7 days in Hyderabad. Okay, this is for lab. Okay, second, I have another training this thing for operative histro. Okay, and another is there for advanced, that is retroperitoneum. Okay, take it out.
Sir, how many cases each fellow will get, sir? Because I know about you, because our fellows PGs are asking.
No, ma'am, these are all camp patients. Okay, these are all poor ladies from villages of Maharashtra or Telangana. Okay, so it is like up to you. Okay, how many are, what gets you confidence? Okay, so that many we can accumulate. But according to the course, we give hands-on for 4 cases. Yeah, I'm done.
Sir, is it complete hands-on, or you'll show us first on endo trainers?
I don't use endo trainers. I don't encourage also, but in your initial PG period, I would advise in PG time you should practice on endo trainer. Okay, once your PG is done, once your PG is done means you are ready for market now. Okay, not ready for endo trainers. So it is not. So like it is on patients. It is not on endo trainers. Endo trainers only endo suturing. Okay, because endo suturing is a skill that you need to practice it again and again.
Sir, these few small silly questions I'm asking, sir. For example, if we don't have any touch, for example, as a postgraduate, if we don't have any touch in laparoscopy, like we don't have
That
any
is the
knowledge.
most common question I get, but I wanted to ask you, see, anytime when you do, that will be your first time, no? So whenever you do, one time it will become first time, no? So if you take a call, whenever you pass a PG, or let's say, I have trained my oldest fellow, is not even Pramila madam. Pramila madam is very young. Okay. My oldest fellow is of 77 years old. Okay. So it is not like she got motivated at that age. Okay. So it is not like, and now people just pass out what they think. Is it okay to go, or should I get trained? Wherever you go, that will be your first only, no? So rather, it is not like that. I should be experienced enough to go for 4 days training.
Yes.
Okay, at least I should be doing something. Nothing like that. Because it is, and it is not even like that. If I have done at least like 100 open hysterectomies, then only I can do lap. See, both are different modalities. Okay, lap is completely different. Open is completely different. Okay, but it is a hysterectomy. Surgery is the same. Okay, but modalities are different. So even if you have done 1,000 hysterectomies, no, then also doesn't matter that whether you can do lap or not. Okay, even if you have done 0 hysterectomy, then open. Okay, then also can you do lap or not? That is not at all related, because both the modalities are totally different. Okay, what else?
Like whom to consult? Because I know the details, sir, but
that guy and this guy.
Dr. Chintan sir and Dr. Sandeep sir. Sir, like we want to associate with you, sir, like any group, like we regarding updates
Yeah,
of
we
your
have so many WhatsApp groups, ma'am. You can forward it to
academic
them.
details, like
Okay,
any
and
workshop
already I think we have already made one Eagle group. Okay, I think all the residents have been added in that group. That we made one group. Okay, so just follow that group only.
Okay.
That group in this year we are going to add continuously, whatever programs we are doing. Okay, so that only will be a point of contact between you guys and me. Right?
not only
I stay in Hyderabad only. So I go to Aurangabad only for this training. I am not from Aurangabad. My brother is from Aurangabad.
Sir, doubt, sir, like is 4 days enough? Is 7 days enough? Even though we don't have
you
any
came
knowledge.
for 4 days, no? Rather than like me, boasting about myself, you should tell. You came for 4 days.
Sir, I already said, sir, but they want to know from you, because
you have live customer here, so I.
Because I have little knowledge. I had little knowledge before coming there. So our people are asking, like, we don't have any knowledge. We didn't even touch the
doesn't matter. Doesn't matter.
We don't know anything about the instruments.
Our favorite madam is not here. If she is here, she would have stopped you to answer that question.
Sir, then one more thing is, what we feel is, if we come there and get trained, and it is necessary to come back. It is necessary to come back and practice, no, sir. If we don't practice, we'll forget, no. So how we have to
do some
modify our
meditation.
future.
Don't forget.
How to modify, sir, our how to plan.
See, our field, surgical field, is a skill field. Okay, so skill, if you don't keep on doing, obviously once you do after 1 year, let's say you are driving car, suddenly for 1 year you are not driving. So suddenly after 1 year when you sit on car, you will find it little bit, hesitation will come, no? But if you keep doing daily, then this is like, it becomes your second nature. Okay, now if you tell Ravi, no, there are 10 hysterectomies, Ravi will like, okay sir, 10 only. Okay, so it has become second nature for them.
So keep saying, keep doing till it becomes a habit.
So keep doing till it becomes an habit.
Arey madam, acha.
So age is not limit.
Age is not limit. We were discussing about you, madam. We have 5 sets now. We have 5 sets. If this is not working, even they can put that camera.
But that connection, audiovisual connection, everything is kept to this.
2 minutes, ma'am.
Above also they have thing.
2 minutes. If you remove this camera box, they'll connect the wire on that camera
Don't
box.
want to take any chance. They don't want to take.
Okay, so don't let anyone touch that board.
Back. So we want to know about your academic, like this, for example, here workshop you are conducting, like anywhere you are any interesting case you are doing. So we want to know how we'll know, sir.
You can reach to my YouTube channel. You can go to my website. Okay, there you will get all the upcoming conferences. And mostly he looks after that, but I head the Andhra, Telangana and Uttar Kannada for Foxy and IAG. So wherever like this side you have a conference, if I am available, I only will be the operating faculty. If I have to accept.
Yes.
It is like, but madam invited, that's why we came, or else we don't come this far.
Okay. Thank you, sir. Thank you, sir. So as surgery is going on, we'll ask the experience of our postgraduates who are here. So first, Aishwarya.
Record the video. The Foxy also.
Because this is record. Please record. One of you record. Because Foxy, as it is a Foxy Eagle project, we want to record few things because they've asked to upload so that we all will get certification. So they have asked about the experience of the different people, like faculty, postgraduates who are attending this. So first, I would like to ask the experience of our
be straight.
Postgraduate.
No need to be. Sorry, here I have to tell good.
Third year postgraduate, Dr. Aishwarya. So to tell your experience about this Eagle workshop and laparoscopic workshop by Dr. Jugal Patel, sir.
Firstly, sir, thank you so much for accepting the request of our HOD madam and coming to our college, sir. It was a great experience for us as a resident who has never held who has never been introduced to laparoscopic instruments before, who has never held it. It was a great experience for me to do even I could do a laparoscopic hysterectomy under your guidance. It was a huge honor, sir. And this inspired me to learn more about laparoscopy, and also you motivated a lot of our residents also here. And definitely most of us will be joining a residency program, or probably will be interested in the laparoscopic fields in future. Thank you so much, sir, for motivating us.
More than happy, ma'am.
And thank you HOD madam. Actually, it was all HOD madam who had called you and who had made us
this entire thing is her idea. Okay,
Yeah.
I am just, what do you say, I am just a Narad Muni. Okay, so I have just come because of her.
So then I ask the experience of the faculty.
You take anyone's this thing later.
I'll ask the experience of the faculty.
Thank you. Congratulations.
Assistant professor. So, Dr. Karuna, assistant professor. So, how is your experience? How you are feeling to see this live laparoscopic workshop?
We have seen number of cases. Sir, we have seen number of cases, sir. Like myomectomy yesterday night is a very difficult case. Sir has done it very easily. Thank you, sir, for giving us this opportunity to see these difficult cases. We will learn more, sir, from you. Thank you, sir.
Thank you, Karuna. So I would like to ask another postgraduate. So Dr. Anjana, she is second year postgraduate of our hospital. So how is your experience, sir? How is your experience, Anjana, regarding this laparoscopic workshop?
Good morning, everyone. And really, I'm very grateful to see such a setup, laparoscopic, as we never saw, as we only studied in the books and we never saw the instruments, never held the instruments. It's a very great opportunity to hold the instruments, assist the surgeons and see the surgeries direct, and expecting more to learn, and definitely expecting me also to learn the laparoscopy, and this makes more interest in the laparoscopy in future, and definitely will visit the sir's residency for the training, ma'am.
Thank you, Anjana. Madam, so here two cases have been finished because today it got late. Both cases are plain TLH only. Today we have kept all TLH normal cases. Only one case is big fibroid, which we will remove by morcellator, endometrial ablation. Other case we will show the endometrial ablation. So now they are extubating and we are shifting the patients outside. So please wait for a while. We'll shift the cases and we'll be shortly delaying the workshop. Thank you. Live workshop. Thank you. నువ్వు చెప్పినా నా కేసు కేసు చెప్పి అన్నా సార్
Good afternoon, everyone. This is the second case. She is a 49-year-old Paris woman with AUB for evaluation. Her ultrasound shows squirrely submucosal fibroid or polyp, but MRI showed 1.8 into 2.5 into 1 centimeter endometrial polyp in upper uterine endometrium. Dr. Bhuvana ma'am, Karuna ma'am, and Kirti Sagari ma'am. Mom was putting the main port and she introduced various needle.
It is in place, you sure?
Pneumoperitoneum was being created through Verris needle.
Still not in. Yeah.
సిస్టర్ బయటికి వెళ్ళి మాట్లాడు.
ప్రెషర్ 14 చేయి.
స్టార్టింగ్ ఆల్రెడీ
ఫస్ట్ ప్రెషర్ ఆఫ్ చేసి 14 చేయి. ఫస్ట్ ప్రెషర్ ఆఫ్ చేయి. ఆ 13 ఉంది కదా, 14 చేయి. ఆన్.
Will you tympanic?
Yes, sir. Yes, sir.
So that was
Verris needle is inserted and we are waiting for the pressure. So the actual pressure should meet the Actual pressure and already preset pressure will be there. Both of them should match each other. Then only we will remove the varus needle.
Or once you get the adequate insufflation, once you get the adequate elevation, okay, that is also enough. Okay, so you have set the pressure to 14, slowly pressure is going to build. Okay, so once you either you get the adequate elevation or once you reach to the set pressure of 14. Okay, so I think you got adequate elevation. Take it out. Okay, take it out, enlarge the same incision, make it 1 centimeter. Only skin, no deep cuts.
Little above, sir. Little above. Okay.
Perpendicular? Yeah. Okay. Now screwing more, pushing constantly. Port hold change. Bonna madam? Port hold change.
Straight perpendicular.
Screw more, perpendicular. Yeah. Screw faster. Inca. Screw. Keep screwing. Yeah. You felt it? Yeah. Push little bit. See for 1 centimeter it is freely going or not. Yeah. This is the only thing what we do blindly. Right. So this we go by feeling.
So even with pneumoperitoneum, so when we are putting this main sharp trocar, so is there any chance of injury, sir?
With pneumoperitoneum. See, obviously when you are careless, all the structures are inside. So what I told before, if you are careless, you are about to injure. But when you understand, see now how she entered, she didn't enter buchuk. Okay, in controlled manner. So even if you are punctured, let's say, okay, it will be a pinpoint. Or even if you have, let's say, 1 centimeter puncture, then also it will be there. Okay, but when you go buchuk like that, then when port trocar is not in your control, then you might injure more structures. Okay, so that's why screwing helps you more rather than pushing.
Okay. So screwing more, pushing less.
Screwing more, pushing constantly, not less.
Yes.
Constant pushing. There should not be any abrupt increase in pushing.
Okay. Light source. Gauze piece పెట్టండి దాంట్లో పెట్టే కర్మ అంతే ఇట్లా పెట్టుకో
Okay, check the entry where she has come. Where is 10 mm trocar? Okay, everything looks okay?
Yes, sir.
Yeah. Head low, ma'am. 7.
So regarding white balance, sir. So first time we have to check, sir, before entering into the abdomen.
See what I told. What is white balance? Anyone? I have not explained it to you this, but what is white balance? White balance in simple language. White balance is nothing but you are telling the camera that this is white. That is white balance. Okay, so to do the white balance, 2 prerequisites. First, hold perfectly white object in front of camera. Okay. Second, that object should not be transparent. That object should be opaque or else light will penetrate. Right. So hold the object. Now whatever system you have, we have stores here. Okay. Whatever system, stores, Indian. Okay. In all the systems, you will have one dedicated button to do the white balance. Okay. So hold the object, press that button. Now camera will consider that as white and will adjust its setting automatically. Then why white? You remember physics? White is presence of 3 primary colors in equal proportions, red, green, blue. So when I am doing white balance, can I make a statement that I am doing nothing, but I am setting up the color perception of the camera?
Yes.
Right?
Yes.
So remember, white balance has only thing to do with the color perception of the camera. What do I mean by color perception? See, this yellow is looking yellow. 1 second. So this yellow is looking yellow, right? Now I do, let's say, white balance here. Now camera will consider that yellow as white. Ma'am, sister. Okay, so see here. Now this is yellow. Now I'm telling you, I'm doing white balance, means I'm telling the camera, think this as white and adjust its setting. Now I'm pressing the button. See, fail. Again, white balance fail. Because camera, in this camera you are getting, because this is German. Okay, in Indian camera will consider that as white and your entire picture will turn like blue. Okay, green. Okay, that means that white balance has not been done correctly. So what to do? Come out, do the white balance again. Now go inside. Now tissue is looking like how it is supposed to look like. Means color, momentum is yellow, how it is yellow. Tissue is pink, how it is pink. Okay, that means color perception of the camera is good. Okay, but image is not good. Image is something like this. That means camera is not good. It has nothing to do with white balance.
So camera cleaning, what you will suggest, sir? Hot water, what you will use, sir, for camera, to clean the camera? Iodine?
Who wears spectacles here? Anyone? Madam has. Okay. So how you clean your spectacles? Normally, you take some wiping solution. Okay, nowadays so we don't do, but it is just the temperature difference. You see, when you go to cold weather, you will get fogging of your spectacles very often. Why? Because weather is cold, and at the same time, when you are wearing a mask, okay, your breath is coming, which is very hot. Okay, the weather is cold, your breath is hot. So because of the temperature difference, your spectacle gets fogged. Okay, so how to deal with that problem? Either you make your spectacle removed. Okay, second, in laparoscopy we cannot remove the camera, right? So either you remove the spectacle, or secondly, you make the spectacle in the same temperature of outside or of your body. So there should not be any temperature difference. Or you have, if someone is wearing lens, what is that lens solution? It just stays on the lens. So, or you cover your spectacles with that type of some technology, so that temperature difference won't reach to the spectacle. Right? So all these three things. So there are three ways how people clean the camera. One, they don't create temperature difference. So outside weather, okay, outside weather is 22 degree. Inside human body is 37 degree. Right? From 22 degree, when you go to 37 degree, it will get fogged. Okay. So either you make camera at 37 degree. Okay. So they do it by dipping it in hot water. So idea is, okay, so you make it 37, 30, 40 degree so that there won't be any temperature difference. So one way, do it with hot water. Okay. What I prefer, hot water, again and again, opening, closing, okay, make it hot. Okay. What I prefer, use Savlon. So Savlon forms one film over the lens. Okay. So that temperature difference doesn't reach only. No, I use Savlon, this Savlon. Okay, what Savlon does is, Savlon just be like, there will be one film of Savlon remaining at the lens, on the lens, so that the temperature difference won't reach. Okay, so for 20-25 minutes, till the time Savlon is there, till that time you won't get that fogging. Okay, once again that Savlon is wiped off, you will again get fogging. So come out, clean it, dip it in Savlon, again go inside. Like that. Okay. Ma'am, inka head load. Do. Right tilt one. Ulta. Yes, sir.
So are there cases, sir, like without manipulation?
Continuous. Do.
So in your training, we have learnt with manipulator and with screw. So for example, in cases previous two sections where because of the fibroid, yesterday we have seen like not able to reach the cervix only. So even without manipulator, will you do, sir? Like,
yeah,
can
we do. But manipulator in your early days gives you proper demarcation. As I told you, everything is on colpotomizer. Okay, uterine you need to send below to the level of colpotomizer. Bladder you need to send below to the level of colpotomizer. Cutting exactly on colpotomizer. Okay, so all these steps makes it simple. You need not worry about the anatomy. when you in your early days, when you are what do you say, confused about the anatomy, what is where, okay, where cervix is ending, where vagina is starting, how much bladder I have to send it down, how much uterine I need to send it down. Okay, in that way, colpotomizer gives you clear cut demarcation. So it makes your life easy. But if it is not going, there is no other option, then there is only one option, that improve your anatomy knowledge. Bona madam, after answering the question, go ahead.
What is this?
Okay.
Connection.
No need for dilation, ma'am. Go ahead. Hey, Shinu ekkada? Shinu ki polo.
Sir, I have asked you that question. Aurangabad I have asked that question.
The same question. Huh?
Same question. Here, skin.
There. वहाँ पे क्या कर रहा है?
Sir, we are using only 2 ports here, contralateral ports. So will you use other port also, sir? For example, bowel is coming back.
Yeah, you can go ahead with 4 ports also. There is no, as I told, there is no hard and fast rule for 2 ports. Okay, I just showed that it can be done with 2 ports also. That doesn't mean that you need to do with 2 ports. Bipolar fire.
Bipolar, sister.
Foot pedal ఇవ్వండి మా.
Foot pedal ఉంది, sir. Shearer ఇవ్వండి. Shearer ఇక్కడ.
సరే అది అవసరం లేదు. అయ్యో. సిస్టర్ ఏం చేయకండి, మీరు అక్కడే ఉండండి. You take this thing towards you. Foot pedal దే there. అది అవసరం లేదు. ఆల్రెడీ ఉంది కదా ఇంకా.
First one, sir.
Press. అరే one second. Fire.
మా ఏంటిది ఇది ఇచ్చారు సిస్టర్.
బ్లూటూత్ చూడు.
హార్మోనిక్ ఇచ్చారు.
హార్మోనిక్ కాదు.
Sir, this is Max. Mine, it is like this, sir. It's not working.
Max. Arey, this is not Alan, no?
This is not something different.
चिंटा वाला एलन वाला. एलन का कौन है इधर? Don't press till I tell you.
No, sir.
Fire. Open.
Phone కట్ చేసుకో.
No. Okay. Don't press now. Okay.
Now you are using bipolar, sir. Whether we can leave that like that on, sir, without coag, it will.
You can. If it is not oozing, you can. Okay, hand down. కొంచెం సెంటర్ రోడ్ బయటకి తీసుకో. You go closer. Your only job is hold it like you are holding a mobile camera. Okay, nothing I want you to do. Only mobile camera, whatever she is doing, just keep it in center. That's all. ఇక్కడ you're okay no sir, so you tell me in between, so they all will be barging inside your department. Okay, so she has coagulated there. No bubbles, no firing. So you will be coagulating or sealing at 3 levels: central, medial, lateral. Okay, they are okay. That is in center. What she is doing? Make sure you don't touch her. Okay, so she
when
has
each-
coagulated all three adnexa at 3 levels: central, medial, lateral. That is lateral. Go ahead. Yeah. Okay. Now no bubbles are coming everywhere, so tissue is ready for cut. Center rod push kara. Go ahead. Now good. That what she has done is she has maintained distance at least 2-3 centimeters away from the uterus. Tikkar ki alandi ma'am. Come on. Don't hold it like a robo. One second. Don't do anything. Nothing. Not used to means nothing you have to do. Okay. Only imagine like a mobile and keep it in the center. What she is doing. That's all. Now she will be maintaining 2-3 centimeter distance away. Perfect. Go ahead. Keep chopping. See, Aishwarya and see how it is supposed to be done. How imagine like a scissor. Okay. How she is doing. How she is cutting. Keeping the instrument open. Okay. Activating the cut current and simply closing. See, already she has reached to the level of isthmus. Now once she has reached to the level of isthmus, you can see. You can see here this faint white line.
Yes.
Yeah, this faint white line. Just show it with your this thing so that it will be visible. Show the faint white line. Below. Here it is.
Yes,
faint white line. Okay, what is that faint line? White line, as I told, that is free UV fold coming and getting other to the uterus. Okay, faint white line. This one. So, in fear of bladder, we tend to be very close to this faint white line. Okay, bladder will be there. Bladder will be there. No, have some confidence. Maintain 2-3 centimeter distance away from that point of adhesion. Because if you stay very close to that point of adhesion, it will be very difficult for you to push the bladder below. Okay. So, she is maintaining 2-3 centimeter distance. And cameraman, woman, this thing should be in center. You have kept this thing at 4 o'clock. Okay, so she is giving UV fold cut from right to left. Koncham paiki. White line is, yeah. Keep doing.
Activate.
पानी बोतल क्या चाहते हैं चला scissoring action. Myomite just standing. You have rotated the specimen. Inka koncham. So anatomy, so you hold it in a way so that anatomy. Now see uterus how it is. This lady has to show you first. One second. Leave this. Now, leave it. Okay. Now see anatomy is like this inside your mind. Okay. So keep the anatomy like that only. Don't make the specimen wobble.
Okay.
Go ahead. Yes.
So first we have to open.
Activate. Open, keep it open. Same, imagine like you are holding a scissor. Okay, open, activate the cut current and close. Go ahead.
So till what extent we have to, like my hand?
Till you can reach.
Yeah.
It is not a hard and fast now. If you are able to reach.
Able to reach. Till here only I am able to reach.
You will be able to open. Open. See? This is your hospital instrument, no? It has gone.
No, sir, yours only.
No, mine only, but the hospital, no, G. Okay. Now you have given cut whatever, how much ever you can from right to left.
Yes.
Okay, now next step. Step number 3.
Yes.
Okay, to push the bladder. With this cut, you can see that 90% of bladder has already gone below.
Yes.
You can see that elevation.
Yes, sir.
Okay, bladder is not there.
But
remaining 10%. Okay, by swiping.
This I want to, this yellow one.
Yeah, cut it.
Can I cut it?
Yeah, you can cut it. Hmm. Okay, so she's simply swiping. See, nothing. In entire process, we have not held the bladder at all. Okay, and bladder is already gone below to the level of colpotomizer. Once bladder goes 2-3 centimeter below to the level of colpotomizer, it is end of that side of bladder dissection. Okay, now next step is to go for uterines. Yeah.
So only after completing uterines have to go that side, sir. Can I do that side same initial steps?
You can do. If you want to increase your time, you can.
Okay. Just for doubts I'm asking.
Yeah. Hold it nicely first. Hold it. And isthmus short, no? How you have held it, right? Now, is it better or this? Hold it. Yeah. If you do it like this, why this is better? Because you are able to do the same thing without creating traction on the uterines.
Okay.
What I told, sealing time, low, hold maximum. First, rule number 1. Rule number 2, tissue should be relaxed. So, relaxed tissue can be achieved by this type of prongs. It is not like if you do it like this won't work. Okay, it will work either way. Okay, but you have to do it in a way so that you don't create a traction on the tissue.
Okay.
Okay, then slowly moving lateral. Chindia. Lie.
वो नहीं होगा मैडम, ऐसा वो काम नहीं हो पाएंगे उससे, क्योंकि वो एडमिनिस्ट्रेशन का है ना पूरा। हाँ, उसको पूछता हूँ।
Now recheck.
Okay, no bubbles, no firing.
Recheck, sir.
Okay.
Okay.
Now you will cut it in between and make sure at this level, see, when you activate, show the entire this thing, prog, camera woman, come, see this. Okay, so when you activate, this instrument will be activated from, come ma'am, little bit back ma'am. So this thing will be activated from here to here. This will become hot from here to here. Okay, so make sure that this entire thing, if this entire thing can seal one tissue, can cut one tissue, it can cut this tissue also.
Okay.
Okay, so make sure when you are doing this, it should not be touching anything from here to here. This black is okay. The black is insulated. Okay, till this thing, and at least once your job is done also, for at least 2-3 seconds, it has just cut the tissue, and after like coming back, you want to come and touch this serosa, instantaneously it will get coagulated because that is very hot.
Okay.
Okay, so make sure you don't go here and there.
Okay.
You stay within the camera limits.
Okay.
Okay, go ahead.
So the elevation is helping me.
Yeah, so you need to ask your madam
to elevate.
And adjust the myoma, maintain the anatomy. Yes.
Yes.
Chop it.
So first activate, open,
and close completely.
It's not.
See why the current, we are not able to see the current also. The same this chart tissue has got stuck here. So you need to clean.
So instrument has to be cleaned with solution, sir.
So ideally, see what ideally it is just like how you clean your vessels after eating. Okay, all the dirt, whatever is attached, you need to remove it, right? But the fastest way to do that is we use enzyme cleaner, okay, or tissue lysing agents, okay, which will lyse the tissue which has got stuck on the prongs. Okay, cheapest enzyme cleaner available in Indian market, which will be available from small nursing homes to big hospitals, will be peroxide.
Okay.
Okay, so you just dip it in the peroxide, it will lyse the tissue. You just wipe off the charred tissue, and that's all. Your instrument is done. There is means like to do the hysterectomy, ma'am. To do the hysterectomy, obviously you need to cut the uterosacral. But at what time you need to cut? Okay, so we prefer to do it at the end. Initially, even if you do, doesn't matter. If you follow my ditto same technique, ma'am, ureter, see why we do it before in open surgery, why we cut the uterosacral before is, when you cut the uterosacral, ureter will go little bit more lateral. If this is uterosacral, okay, coming to this, what madam is asking, there is no need to take the uterosacral. Okay, so what is uterosacral? This is the traditional way of doing hysterectomy, is like this is uterosacral, right? Now to remove the uterus, obviously I need to chop it. Okay, so whether to chop it now, okay, or later when I come with my colpotomy. Whenever I am doing my colpotomy, obviously I am going to chop this. Okay, but whether to chop it now or later, that is like doesn't make any difference. In open surgery, what previously they used to do is, when there is not that much amount of traction, okay, when you cut the uterosacral, when you chop off the posterior layer of peritoneum, it will give you some space because ureter goes more laterally in open surgery. In lap, when you have this much amount of traction, ureter is already lateralized, so you need not worry about uterosacral, this thing. Only what you need to worry about is colpotomizer. Okay, all the structures should go below to the level of colpotomizer. As I told you yesterday, any hysterectomy means lateralization of its artery. So once I send my uterine artery below to the level of my colpotomizer, that means uterus is free. I can chop it off.
Activating.
దగ్గరికి So again, no need to retract it back. Yes, okay, imagine like a scissor. Okay, hold it, ma'am. So we went there. This is the lumen what she has cut. Okay, okay, sorry, seal chandel. Hold, seal. Enough. Okay, now we saw the lumen. This is the lumen. Now what I told, the tissue which is holding the lumen with the uterus, you need to assess that tissue again and again and chop it off. Now this tissue is holding, chop it off. Continuous, close, close, close. Yeah, okay. My uterine went little bit down. Now which tissue is holding? This tissue. Okay, chop it, activate, and continuous activation, and close, close. Yeah, again my uterine went little bit more down. Okay, now which tissue? This is my lumen, this and this tissue, both. That madam's uterosacral also. You can chop it at this level also. Right? Go ahead, chop it. Yeah. Okay. Now this tissue, this uterine, which tissue is holding the uterine? This tissue. Right? Chop it. Close, 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 close. Right? Now uterine has gone till this level. Now I'll just identify where is my colpotomizer. Close. So this is my colpotomizer. This. Okay. This is where I'm going to cut. When I'm going to cut, my uterine is not going to come in my way. Correct? Go ahead. See. Seal. Enough. No need to cut. Yeah. Okay.
ఇక్కడికి వచ్చి ఇక్కడికి వచ్చి లోపల ఎక్కడ ఇక్కడ వచ్చింది తగ్గింది కాదు అక్కడ తగిలింది కాదు కాదు అది కాదు మయం వస్తుంది తీసుకున్నాం అది సార్ పిల్లవాళ్ళు కదా సార్ బాగుంది సరే సార్ దగ్గరికి వెళ్ళి డింపుల్ ఓకే చేస్తావా నేను పట్టుకుంటా తిని చేస్తూ సరే తెలీదు నేను చేస్తా ఎదిగినట్టు పెట్టు చూడిస్తారు త్వరగా చేసుకుని ఇంకేం అది మొత్తం పట్టుకొని కన్నా ఎక్కువ ప్రెస్ చేస్తే కట్ అయిపోతుంది అప్రాక్సిమేట్ చేసుకొని ఫస్ట్ ఎక్కువ లైట్గా ప్రెస్ ఇస్తాడు చూపిస్తుంది ఇదిగో ఆ పొట్లో నుంచి రావాలి క్లోజ్ చూసుకోలేదు ఒక్క నిమిషం ఇది ఎవరైనా పట్టుకుంటే బాగుండదు ఇది ఆర్తి గ్లౌస్ మొత్తం పట్టుకోవచ్చు మొత్తం పట్టుకో ఓపెన్ మొత్తం పట్టుకో ఓపెన్ ఇంకా ఓపెన్ చేయి బాగా పట్టుకో క్లోజ్ ప్రెస్ చేయకుండా గట్టి పట్టుకోవద్దు ఇప్పుడు ఇచ్చి ఫస్ట్ చేయకుండా ఆపద్దు ఓకే నెక్స్ట్ మీడియం గో మీడియం లేటర్ మొత్తం పట్టుకో So other side also we are following the same steps.
Yes.
Bubble stop, we stop. Then medially.
Rotate side. Camera rotates. So make it
Rotate.
horizontal. Yeah. Okay. And don't go so close.
Okay.
So that it is not visible. The more entire thing, if it is visible, more confidential.
Okay. Interest me also. నొక్కి పెట్టుకో ఎస్ ఓకే recheck again recheck so we are following the same steps of rechecking recheck again only see stop next later medium again same cut next cut activate ముందుగా activate control close జాగ్రత్త so activate instrument open activate
Once you are done, you will move space of axis.
activate open cut
Activate, open, close.
sorry close
Activate. First activate.
activate cut me activate close yes just cut both leaves activate
There is no correlation.
activate
Necessary to
activate open activate
Not, it is not
Cut.
mandatory step. No, if a woman has a good pelvic tone, what is the need?
open
So as I showed you, as I told you yesterday,
Okay,
see,
so black.
see, suspension. See what she is asking. Okay, question is it necessary? What is the occurrence of wall prolapse? Okay, post hysterectomy. Okay, and how to prevent it? So what my thing, one second, ma'am. What I am trying to tell you is like what we are doing. Okay, if I am suturing, okay, I am taking uterosacral at the same level. Okay, here. So I am not doing high uterosacral suspension. Okay, high uterosacral suspension will prevent. Okay, what is high uterosacral? Okay, somewhere here because this side sigmoid will be there. So
That's
this
the
side.
instrument which is just now used. Can be hot. It will be hot, no, sir. No, can we
Okay,
touch the ball?
that's why I am touching. I have dipped it in blood.
Okay.
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 Okay. So see
Uterosacral.
hand aside. Relax, relax. Okay, so see the. No, take it up. So this is my uterosacral. This is my uterosacral. It has already good strength. See how much taut it is. Okay, if this is loose, okay, it is simple like a hanger. Okay, if this area, what is wall prolapse? Is this area when you cut it, this area will become loose. Okay, so I just want to hang it. So where we'll hang it? We will hang it to which is very, very hard. Okay, which can hold this weightage. Okay, so that's why we hold it to ligament. Okay, now that is the final, that's sacrocolpopexy or pectopexy, that yesterday what we showed. Okay, just to prevent there, we do something called as high uterosacral suspension. So somewhere here, okay, here though it is not coming also, but when it is lax, okay, this will come and this I'll tie it to what? This is high uterosacral suspension. Okay, when I am taking it in this thing only, suture, I am taking this uterosacral. This is not going to prevent. Okay, I just have an advantage of taking it in the suture, that's why I am taking, but that is not going to prevent the prolapse. Okay. Rotate the camera.
So for example, camera this side is better.
Okay. So be between uterus and her instrument. So first shot you need to give at the level of isthmus. Your isthmus is still free.
Whole chunk. Stop. Above. Below. Okay. Don't leave the cut. Approximate. Don't crush. Yes. Next below. Open. Whole chunk. Then till the bubble cease. Recheck. Same recheck. Like first one, seal. Stop. Recheck. Same places you recheck. Move up. Same. Recheck. మొత్తం పట్టుకోండి. Recheck. Cut, sir? Okay, cut. Activate. Open, activate, close. Open, activate. Activate. Cut ne activate cheyu. Close completely. It should be under control. Open, activate, close completely.
Where first of all see. Okay, this is my uterus. Okay. So first step, send the bladder below. Close the instrument. Make sure this is yellow. Okay, so this is not your plane. Your plane is below. This is vesico-vaginal space. Okay, in vesico-vaginal space, if you find fat, that belongs to bladder. So I saw fat here. Okay, so my vagina is still not clear. I need to send fat with bladder. Okay, so there is, of course, there is no bladder in it, but fat is there. So I've sent fat with the bladder. See, with the bladder. Okay, now open. Now you cut it here, right? So this is my uterine. This one, lower prong where it is touching. No? So hold it first. Seal it once. Yeah, see that structure, round structure. What you are holding? That is uterine. Seal it once. Enough. Okay, you have sealed here, sealed medially. Okay, open, seal laterally. Okay, so both the side it is sealed. Now you cut it in the middle. So we bend, we support it. Okay, then activate the cut current and simply close. See, now you can see your uterine lumen. Okay, now once the lumen is seen, which tissue is holding this lumen? Okay, lumen is going below. I want to send this lumen below to the level of my colpotomy, so that when I do my colpotomy, my lumen should not come in my way. Okay, lumen is leaking. So hold it, fine, see. Okay, now this is my lumen, so I'll just make my colpotomy ready. Cut it. Okay, I come. Now this area, chop it. Yeah. Okay. Uterosacral also, chop it. Yes. Okay. Now uterosacral will always contain capillaries like this. Little bit close one. Close little bit. Close instrument.
Huh?
Not you. You have to close little bit. See?
See.
Here. Okay. So now this is my colpotomy area. Colpotomy is free of uterine. So when I am going to do my colpotomy, my uterine is not going to come in my way. So that is end of that side. Take it out.
This is this is. Sir, when you will use bipolar, sir, because it is a shearer, it is having options of both the sealing and bipolar. So in which cases you will use bipolar?
It is just the current.
Current
so
only.
I
Correct.
use always seal mode. Okay, there is no bipolar.
Choose.
Okay. So you are not able to see because you have not sent the fat below. Okay. Okay. So I wanted to see there is one areolar tissue. I just took care of that areolar tissue and nicely fat went back. Now you wanted to see that sunrise of colpotomizer. See, now you are able to see that white of colpotomizer. Okay, so this is not bladder. This is just some vesicovaginal fascia.
Even if you take also nothing.
Even if you take, nothing will happen. But you should have that estimation that yeah, it is there. Right? Go ahead. Come on. Any? Red tissue.
Like this, we want to again put bipolar or something. She's asking.
No need. Go ahead. Go closer. Tip. Tip to this side. Camera side. Okay. Cupid. Go ahead.
From here I
Go. Take that bit also. Follow. Hand down. Hmm. Hmm. Hand down. Don't move more. Okay, keep it stable. Hmm. Okay, the same you can show by going below.
Can I go like this?
Yeah. Go. Go. See that uterosacral? As I told you, uterosacral is always a culprit. Okay, so when you do cutting with unipolar, okay, unipolar doesn't have that much sealing capacity.
Can I take bipolar now and see?
Yeah, you can, but you have already
Sir,
finished.
usually in traction, if we do bipolar, we are
Compromise.
So in traction, for example, you are going with endosuturing. So what we are doing here is we are not practicing endosuturing, sir. So with traction, shall we coagulate the? Shall we coagulate or?
When it is under traction, now it is already under traction. So even if you want to coagulate at this moment only, you should coagulate. And best will be to have it with flat bipolar. This shearer, the tip won't work that much. Where flat we don't have. Go ahead with shearer. One second.
So we'll pass the instrument without seeing the entry
Hand
point,
down.
sir. So what you will tell, sir, from the entry point, it's
Always.
posterior.
Okay. It's like my boss used to tell.
Posterior.
Abdomen is like a Pandora box. Or everything under vision.
Here I have seen, sir. Posterior I have seen.
Enough.
Posterior.
Take it out.
I want to see posterior.
Posterior, because this lady should show. No? Okay?
There.
That is okay, ma'am. Come.
Entry point.
Careful.
Down.
हाथ नीचे कर. Push मत कर, इतना push मत कर. Go ahead. Go closer, ma'am. Camera. Keep it in center.
Okay. Bipolar.
Again, you got this vessel, madam
Yes,
was
sir.
asking, no?
I want to see.
So that is only descending cervical. At that moment only, when traction was there, at that time only you would have taken care.
Okay. You said
Go.
no, sir.
Hold.
See, don't worry.
Okay, doesn't matter. Go ahead. Don't pull. Fire. One second. Not entirely, just vessel. Just reach there. That's all. But don't do anything. Just fire. Enough. Below also. Camera. Fire. Hold camera.
Sir, sir is
Tooth ఎక్కడ ఉంది? ఉందా? Going down now. Tell right. We'll be going down. Tell
I'll tell. So after this case, we'll proceed for lunch, and our Chief Operating Surgeon, Dr. Juhul sir, sir will meet all the
No, so what
delegates who are-
we have planned is like after lunch, like we will come to our conference hall and we'll meet all our faculties who are sitting there.
Yes, sir.
Okay.
So sir will come and
before
meet all the
proceeding-
delegates who are waiting in the hall,
Yeah.
and so sir will have interaction, then followed by next case last.
Okay, quick interaction for half an hour local के लिए. ब्लॉक करने चाहिए. ब्लॉक
Yes, sir.
go inside. खत्म. ठीक है कम. ठीक है ओके.
Like it.
अरे go. A toothbrush aspirin. Come back. What is the next step? Next
Needle.
step is
Needle.
not needle. I want to put one another
Okay.
row.
Okay.
I want to hold this now.
Okay.
Ovaries. Sure. दे अभी दे. Go inside. Go. See, like this it should be visible. अरे come this.
We can do, but it is easy.
Come back. Here is the other. Go inside. Go, go. Don't rotate the camera. Okay. Go. Come back. Go. Go. Don't rotate the camera.
It's rotated now.
There is a tilt also. No? So,
Okay.
Straight. Okay. Keeping abdominal wall parallel to the upper border of the screen.
Okay.
Take care. Come.
Scissors is here. Space. Scissors.
Oh, okay. Come 1 second. Now they wanted to show, I forgot that side. You people wanted to show space of edges, right? So coming to space of edges, same తీసుకోకండి మా ఇక్కడ నుంచి షియర్ తీసుకొని వెళ్ళాలి.
Shearer.
Okay, to have a better understanding of space of edges, we need to have, I do it with 2 ports, but you'll understand more. We'll go ahead with 4 ports. Okay.
No need to remove, sir, this one. Cut.
No, keep it. Oh, Ravi को बुलाए. नहीं तो तुम आ जाओ. कोई भी एक मेरे को ये पकड़ने के लिए होना. I am okay with camera, but only to hold.
I'll hold, sir.
You will hold? Ravi will come.
Sir will put.
Come back. Suction on చేయండి. Irrigation. Hemoglobin 10.9 ఉంది. We'll repeat it, Kema. That's what I'm dead sure about the case.
Sir, before closing the vault only, you should take care of all the bleeders, sir. After closing vault.
After closing vault, your traction is lost.
Yeah.
Okay, so when tissue is under traction, at that time only you take care. If you take care at that time, okay, so you need not worry about the traction because now you are dependent on your assistant to hold and give traction. Camera. ఇక్కడ ఇంకా ఒక or X.
So sir is showing now space of ridges dissection. In this case,
इधर इधर इधर
Just a
अरे Okay. So understand what is space of Retzius, also called as pre-vesical space. Okay. What do we mean by pre-vesical space? Simple. English. Okay. It is above bladder. So it is in between rectus sheath. మాట్లాడకండి మా sister. Rectus sheath. Okay. Bladder. Between rectus sheath and bladder, this is pre-vesical space or space of Retzius. Bladder, vagina, this space is vesico-vaginal space. That's what we are dissecting here. Okay. Then comes the uterus. Okay. Uterus rectum. Okay. This space is called as Denonville space. Okay. All are avascular spaces. Okay. To understand, now coming to space of Retzius dissection, we will start space of Retzius dissection at the level. You can see yesterday we saw this is median umbilical ligament, that is obliterated umbilical. Okay, median umbilical ligament. Now we will come and give traction at median umbilical ligament. Okay, another median umbilical ligament, right? Okay, so both the side traction has been given. So what happens when you are, let's say, when you are operating, okay, when you are operating plastered uterus. So in that, this space is obscured mostly. See, I am just chopped off the peritoneum. Right? Now, see bubbles. Keep following, sir. Go. One second. Leave it, leave it, leave it. બોલો ટોપો શું કરે ત્યાં Okay, so I'll just keep on chopping the areolar tissue. See, here you need to understand that bladder is, where bladder is? Below that. Okay, it is not above, it is below. Okay, so I'll keep on chopping. I'll show you bladder, I'll show you pubic symphysis. Okay, so we will reach till the level of pubic symphysis.
Thank you.
Follow, follow, follow. Follow. Go inside. Okay, again in this space also I saw fat. What I told you, fat belongs to bladder. So where is bladder here? Below. So we are okay, we are not bothered. It is not coming and it is going up, but no connection. Leave it. Table which uncomfortable. Okay, so I am only giving traction now. Foot pedal ఇంకా అవలేరా ఇక్కడ अरे सॉरी అక్కడ
सीनो आप चले जाओ
क्या चल क्या रहा है
सीनो आप चले जाओ
એની લઈ જાય ને અહીંયા તો ઓપન સાલા બાથરૂમ એનો Okay, so I am chopping off bladder below. I'm sending the fat, sir. Salon. इसमें auto है.
The space of let's say
ये निकोल. Okay, so see, this is my space. Okay, this is my space. Putting fat below. Fat below. Only swiping. Only swiping. Okay, no extra traction. Now I want the one traction. Come with one instrument. Okay, here if you keep servo inside. It come and hold here. Keep it down. Okay, now this is my urachus. One second, I'll show you nicely. Focusing. Okay, so this is my pubic symphysis. See, I have reached. Focus, focus.
5 o'clock అంటే మనం బయలుదేరి 5 కి బయలుదేరుతారంట. అదే మరి. సరే చూపిస్తాను. సరే చూపిస్తాను.
Okay, can you see this? This is my pubic symphysis. Okay, one second. Ma'am, and ma'am. Okay, na?
Okay.
You will let me know what.
That white shining structure.
What is that
Pubic.
white tiny shiny
Pubic.
structure?
Pubic
Symphysis, right? One second. Again, it will be more clearer. One second. The attraction was. Oh, that's it.
Sorry.
Okay. Keep traction. Okay, nothing. I am just swiping off the areolar fascia. See, I am just putting it towards bladder. Any? Now fat has gone with bladder. Okay. See. Okay, so see, entirely what we have done is we have lifted off the bladder, and this is our pubic diaphragm. You can see, one second, it will be more appreciated if I take care of this. Hold this. Fine. Okay, hold some. Okay, so this is obliterated urachus. So it always hangs the bladder.
So if you remove.
Sorry?
If you
it doesn't, nothing happens. It's already obliterated. It is. Right? Now understand, now see, where is the urethra? Okay. See, now I'm putting my finger inside my vagina. So this is vagina. Okay, this is vagina, or what we call it as paracolpos, this area. This is my urethra. Okay, This entirely is bladder. We will show it to you. 1 second. See now, you can understand. Okay, so this is entirely bladder. Okay, now what we have reflected below. Okay, now if you fill the bladder, okay, when bladder gets filled, when you don't urinate, at that time this is the space for bladder to grow. Okay, so
with the space.
yes, ma'am. So now coming to for SUIs. Okay, why we do this space dissection? It is for stress urinary incontinence. Okay, you need to study the theory and all. Okay, what we do. But in stress urinary incontinence, in surgical approach, okay, there is one surgery, what we call it as Bursch-Colpo suspension. Right. So why it is called as colpo suspension and not urethral suspension? Because we suspend colpos, vagina, and not the urethra. Okay. So coming to colpo suspension, now I'll be putting the finger here. See, this is my left side paracolpos. See, he's feeling it. I'm this one. Okay. So if I put up one bite here and one bite here directly, so this is hand here.
Yes.
Right. Then coming to my right. Oh, just put a finger. Right side. Right side. Right side. So this is my urethra. I'll just slide the urethra towards this side.
We are not able to make out urethra.
This urethra won't be visible completely. We don't want to.
That only.
Okay, so this is urethra. This one. Okay, but sorry.
Will we suspend directly to the pubic symphysis?
Not pubic symphysis. This is only the Cooper's ligament, iliopectineal ligament. Okay, the same thing what we did pectineal ligament. That is below, sir. Arcus, tendinous, fascia, pelvis, that is much below. Remove this. So this I'm completely, what do you say? I'm opening up the pelvis, but I don't want to. Okay, now.
Sorry.
See, this is your obturator foramen. Okay, 1 second. Madam?
Okay,
Okay, time up. Okay, so you can, someone, I think Balaji sir asked. Obturator. Okay, so obturator also will come here. See this, it is going. 1 second. It's like herniation of a fat. Cover me.
So left hand also should it should move like right hand, sir.
The left hand training will take time, ma'am. So left hand, focus on only one hand before. Okay, so I think the idea of this thing is clear. This is space of Regius. So when this thing is obliterated, when your uterus becomes ventrofixed, it is this space which becomes obliterated. So there is like what we need to enter is vesico-vaginal space and not this space. Because in this space bladder is below. We think bladder is above. Okay, we tend to go below, you will open a bladder. So in ventrofixed uterus, you need to have anatomical knowledge of this space. Okay, Cut. Induce.
Now only, sir. Lunch.
No, sir.
Mama.
Lunch, sir.
Sir, our case వాళ్ళు ఇంటిపేట్ చేసిన మీరు అంతా lunch చేసి వచ్చేసేయండి సార్. So that the last 2 cases only.
Okay.
Finish it, sir.
Okay, ma'am. Okay.
మీరు వెళ్ళిపోతే అక్కడ they are waiting for lunch, sir.
Sure.
3 hours sir time.
Okay, bye, ma'am. 2 minutes.
2:30. Meanwhile, they will prepare for next thing, sir.
Sure.
మేము ఉంటాం ఇక్కడ మీరు వెయిట్ చేసి వచ్చేయండి.
Sure.
ఇక్కడ గిఫ్ట్స్ పైన ఇచ్చేద్దాం కదా, పైకి వస్తారమ్మని చెప్పేసి వాళ్ళు.
ఫిగర్ ఒక ప్లేట్ పెడతాను, ఇంకొకటి ఇంకా hey. పుల్ చేయి, పుల్ చేయి ఫస్ట్, తర్వాత అయితే ఇక్కడ సపోర్ట్ చేయొచ్చు. పుల్ చేయి, నాకు తర్వాత ఇబ్బంది అవుతుంది. ఇదే పట్టుకో, ఈ సైడ్. అదే వచ్చేసి వస్తుంది. వచ్చింది. చెక్ ఇంకా ఒక పెట్టండి. పుల్ చేయి. Not bladder, only peritoneum. This is peritoneum. How can I suture bladder?
That's what, like, below that is the bladder.
Below that is bladder, but I am suturing peritoneum. So that, why I am doing that? First of all, I like whatever is normal, keep it normal. Okay. Second, even if there is no urgency or there is no need to close this, okay, you can keep it open also. But what happens is sometimes if you keep it open, some bowel loops might go and get entrapped inside. So for that reason, hold. రైట్ అయిందా ఒక్కటి చాలు థ్యాంక్ యూ థ్యాంక్ యూ
Workshop afternoon session. So we are starting a case of TLH, total laparoscopic hysterectomy. She is a case of 50-year-old with AUB, abnormal uterine bleeding. So sir will do TLH, total laparoscopic hysterectomy, and sir will also show us lateral pararectal space dissection, which is very important for our gynecologists. So where we will see the ureter and external iliac, internal iliac and common iliac artery. So sir will show us the relationship in this case. So everybody is asking about uterine manipulator. Ravi brother, Sandeep sir. Blade. Next blade. Sound రావట్లేదా? Sound రాలేదా? Small neck, that side, turn blade this side. Sister, ఇట్లా పెట్టుకోండి. చేతి బ్రదర్ సౌండ్. సిస్టర్ ప్లీజ్ ఫోన్స్ సైలెంట్ మోడ్లో పెట్టుకోండి, దయచేసి ఎవరు మాట్లాడకండి. మీరు కూడా. So good afternoon everyone. So this is a case of total laparoscopic hysterectomy. She is a case of 50-year-old with abnormal uterine bleeding. Sir will show us total laparoscopic hysterectomy followed by lateral pararectal space dissection. So where we can see the ureter, course of ureter, and we can see the relationship of common iliac, external iliac and internal iliac. Lift. ఇప్పుడు వినిపించట్లేదా? లిఫ్ట్ 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 ఇది లిఫ్ట్ పర్పెండిక్యులర్ స్ట్రైట్ కొంచెం వెనకలికి వి డోంట్ నో డిస్టెన్స్ విత్ దిస్ లిఫ్ట్ పర్పెండిక్యులర్ లిఫ్ట్ లిఫ్ట్ screw lift is gas. So various needle is inserted Sister, uterine manipulatory. Anna, 14. Off chesi 14. Off chesi on. Off on. Idi. Gas on. Huh? So this is Anna. So we can give the contact number. So sir will come and interact with you. We'll give the contact number. You will send courier and send.
So,
Mike. Michael. So sir has come. Sir, everybody wants to.
Designed by, okay, it was designed by Dr. Mandeshika sir. I hardly name my
Game system. No, ఇది ఆన్ చేయమని. మేము ఆఫ్ చేసి ఆన్ చేయమని అది కాదు. రీచ్ అయింది కదా మెయిన్ పోర్ట్. ఎక్కువ మంది ఉన్నారు. ఎవ్రీబడి వాంట్స్ కాబట్టి ఒకరు
relaxant ఇచ్చారా? Okay, so coming to the manipulator. Okay, so this is Mangeshikar manipulator. We call it like
Malish. Everybody please keep silence.
Okay, so this is Mangeshikar manipulator designed by Dr. Mangeshikar sir from Mumbai. Okay, there are some modifications what we have done, what I have done. Okay, so now I own a surgical shop. Okay, named by Kimaya Surgicals. Okay, directly you can buy it from there, or you can directly contact it to me. Okay, just drop a WhatsApp message. For all my fellows, we give it like only production cost. Okay, no this thing. Selling price is different. Okay, now coming to the manipulator, when you purchase new manipulator, there will be 3 cups along with this. It will be given to you. See, this goes. Okay, so remember how we use the manipulator. If this is uterus, okay, so cervix should go inside the manipulator. Then only this will lie on the fornicial level, right? If you cervix goes like this only, then only you will be cutting the fornix. Okay, let's say cervix size is bigger. Cervix is bigger. Okay, then cervix will be like this. Manipulator is this size. Okay, then when you will be cutting like this, you will be cutting the cervix. So remember, identify the size of cervix. Okay, we keep for 90% of the cases, most of the cervices will be normal. Okay, so we have kept one middle one. So you will get small, medium, large. Okay, the technique is your cervix should go inside manipulator. So if cervix size is larger, choose a larger cup. Okay, then only you will be cutting the fornix. Okay, now coming to another thing is this also. When you purchase new, you will be given three this thing. What you can call it, some pins or tips. Okay, you will get three tips. Okay, small, medium, large, whatever you can keep it. The idea is in entire process, this goes inside uterus. What sir designed is this prongs, okay, to hold the cervix. But in the period of time, what we have understood, there is no role of holding the cervix. If you hold the cervix, what happens? If the uterine length, matlab fundus cervical length, FCL, if FCL is higher or longer than this, okay, then this won't be able to reach to fundus level. It won't be able to give you traction at fundus level. If you hold the cervix, if you don't hold the cervix, this entirely will go in. So we just want one center rod to be inside the uterus. That's all. Okay, so there is no role of holding this. So what modifications I have done is I have removed this completely. So that once you remove it, again, again and again, that thing, why the manufacturing defects, problems with the instrument, everything will get lessened. Okay, it is only one, I have made one center rod. No this thing, no anti-version, nothing, only one center rod. So that center rod, you can use it for all the purposes. Wherever you require anti-version, you just use this center rod rather than using the uterine sound. When you use the uterine sound, because the tip is very pointy, most of the time you will be puncturing the uterus, right? Head
down.
low up.
Head down.
Do it continuous.
Sir, in few cases, brother, can you show that electronic end of
do sir.
perpendicular? See there, one hand like this, other hand.
Head low, sir. Do head low. Do.
Yes.
Do.
Screw.
Okay.
Should
Right tilt.
Should not go suddenly.
Continue so channel. First thing. Do. Okay.
Sir, we want to ask one doubt, sir. So there, electronic endoflator is there now. So in few things, first one is what? So because many of
not
us
in few things, in all the machines, whatever machine you have, let it be German, Indian, whatever, or mine. Okay, everywhere you will get three columns. You can see three columns. First is showing 14.9, 47. Okay, you will have three columns in all the machine.
Yes.
Okay. First column is pressure. In that pressure, you will get two columns. That is actual pressure and set pressure. Okay, in that machine, one medically important setting, that is set pressure. To operate any laparoscopic surgery, remember set pressure should be between 14 to 16. Whatever you like, 14, 15, 16. Second is flow. Flow is nothing but how fast you want to insufflate. Okay, it is the speed of insufflation. Okay. So, speed, I keep it maximum. Okay, so this machine can deliver maximum at 20 liters per minute. Okay, so we have kept it around 20 only. Okay, now because already pressure is reached to the set pressure, flow is 0. You can see that 4.2, 0.2. Okay, now pressure, we have set the pressure at 14. Now pressure has reached to 14, automatically flow is going to go 0. Again pressure falls, again the flow will increase. Okay, so the only job of the machine is to maintain the constant pressure.
Okay. Sir, but your mission and all we have seen. First one is actual preset. There it is written, sir.
Yeah.
So what is actual, what is preset?
Here
For
also same. You can see 2 columns there.
2 columns, but here the number is not written. One is
Which
15
number?
only. First number is only 14 we are seeing.
So you can see the arrow.
Arrow.
In between.
Yeah.
Okay. So it can give you pressure of 30, which you are never going to use.
Okay.
Until unless you are doing for some cow or buffalo. Okay. So that's how Germans work. Okay. They make the machine so that it is useful for everything.
Yes, sir. But what I am asking is 2 columns it is written, sir, like 15, 15. Number is there. Here what we are seeing is only the color. See, for example, the radium color 15 is written.
Correct.
So this side it is not written.
Once you switch off the machine, no, that last button. See now, this is your set things.
Yes.
Okay, this is set pressure. Okay, set flow. Volume, leave it. Volume is not important. Okay, so set pressure is 15.
Yes.
Okay, now whatever you want to decrease, plus minus say. So like this. This is set pressure. So first you set it. Okay, and flow also. Once you switch it off, now you can adjust. Now you can see that red thing.
Yes.
In flow also there is 2 columns.
Yes.
One is green one. That is, it is not on, so it is not going. Second is red.
Yes.
Red means we have kept it maximum.
Yes.
That's why it is showing red.
Yes. Yes. Now it is on.
One second. Come this side now. 1 second. Now give me some space. No, coach. Pass. Share it.
2, 3.
Foot pedal.
కాసేపు పట్టుకో మళ్ళీ ఒక్కొక్కరు పట్టుకుంటాం మీరు ముగ్గురు ఉన్నారు కాసేపు పట్టుకో కాసేపు విష్ణు మేడం కింద కొంచెం చూపించండి మళ్ళీ పైకి రండి సార్
ఇవ్వండి ఆ వాషర్ ఇవ్వండి Savlon dry gauze. Is this previous section or anything?
No, sir.
TL.
Yes, sir. She is only tubectomized.
Grasper.
She is not a case of previous section. She is only previous vaginal delivery she had, but she is tubectomized.
Okay. No, but say that. Okay, so in entire process, see how to hold the camera. Don't rotate the camera. See how the anterior abdominal wall got rotated. So the funda is anterior abdominal wall should be always kept parallel to the upper border of the screen. So if you rotate the camera, see how the image changes. If you rotate, how the image changes. In entire process, anterior abdominal wall should be kept parallel. That's all. Okay, forget about this thing. Okay. The punchette layer. ఇది ఒకటే ఉంది हाथ नीचे कर go inside what I am doing. Okay, this is cervical. How come you can give me the case and nothing is there? Hand the side. Array. Tubes over is out.
Sir, she's only age and 50. Huh?
51. I did take it out.
We take it out. Sir, they have given in the scan 5 into 4 centimeters, sir. Intramural fibroids, sir.
This doesn't look. It's intramural only, but it's lower side.
Lower side.
Okay. Stick out in the sino. Okay.
Now what you are doing, sir? Fast you are doing.
So we have already reached to uterosacral level, no? Sorry, uterine level now.
You are removing from previous case and all.
Go inside.
Okay.
Come on. Okay. Tell me.
No, at the end of the procedure we have done
Hmm.
salpingo-oophorectomy, sir. Here starting only you are doing.
So the one side is done. No? So see, in your initial days, okay, because lot of this thing again, what I'm giving with my my hand, I'm giving traction here. Okay, so in your initial days, it will be always easy. Do something. Not like that. Keep it like that. अरे ये बेकार है, ये चला गया है शेयर.
That we bought from the owners.
Already done, ma'am. You must have done the cases now. Go inside. Don't rotate. How the anatomy? Anatomy is this. How you were showing like this above. Come on. Dry gauze. Dry gauze. Okay, so this I'm taking off the uterosacral. Now don't let me tell you all these things.
Yes, yes.
Okay, already we have done so many cases now. Hand down. My window. Come back. Okay, so here I can feel. So myoma is most important. Why? Because it gives you steady traction. Okay, and at the same time, instrument is also very sturdy. Okay, so again and again, you need not keep on changing. See how fibroid, by pulling only it came off. Okay, go inside. Now rest of the steps are similar. I have reached here. I have given the cut from right to left. Now time for my uterine to go. Either I can go completely holding like this. Okay, and this is my uterine. So first shot we'll be giving at the level of isthmus. This is my isthmus. I'll fire continuously till my bubbles stop. Okay, then I'll be moving laterally. Now I am moving laterally. Okay, then final shot will come at the level of colpodomizer. This is my colpodomizer. Again, I'll recheck.
Sir, fumes service.
Okay, recheck. 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 Okay, so this side is done. And this side. Hand. Okay, come here. Come.
I'll touch you.
No. Okay, hold the mark. Now all three structure coming together. Go closer again. Rotated the camera. Rotated the camera. See the anterior abdominal wall. See there. See there. Not there. Not there. See that there.
So it is exactly in the middle, sir.
But you have given the right tilt also, no?
Huh.
So abdominal wall gets tilted.
Okay.
So here also that's why.
Okay. Okay. So what we thought is this head should be in the center. Bottom.
Image should be in the center.
Image should be in the
not
center.
Head.
Okay.
Go closer. Go closer. Not that much. हाथ ऊपर कर. Okay, so I have separated, my bladder has gone below. Okay, this is my uterine. I can make uterine more naked, but doesn't matter. So we can directly go and take care of uterine like this. First shot at the level of isthmus. Will fire continuously till bubbles stop. I'll try to hold maximum. Okay, then again one more shot. This will be my final shot because I have reached to the level of isthmus. See, this is my isthmus. Sorry, colpotomizer. Okay,
So we should not go beyond colpotomizer.
Colpotomizer is your target. Okay, so colpotomizer gives you demarcation in all the steps. Okay, like coming from bladder. So how far you should send the bladder down. Now coming to uterine. So how below you should send your uterine. Okay, so colpotomizer, as I told you, once the uterine lumen goes below to the level of colpotomizer, that is the end of that side, right? Yes. So colpotomizer gives you an idea, okay, how far do I need to send till you develop your anatomical knowledge. Okay, there are so many people. It is not like there are so many people who do without this thing, colpotomizer. So it is just the different way of doing the same surgery. There is no hard and fast rule, but obviously when colpotomizer is there, it makes this thing easy for a demarcation. Okay, yeah, I need to cut till here. See. Okay, once you do your initial 10-15 cases, after that, nothing will require.
So till now, how many cases you have done, sir?
Oh, yeah.
Don't tell some countless. Tell some figures, sir.
Figures more than 15-20,000. More than easily.
15 to 20,000.
Easily. Take it out.
Will there be any special training for camera, sir? How to show camera?
You have to be with me for almost 3 to 6 months.
Okay, sir.
Ravi didn't undergo any training. Just he was with me. That's all.
Which structure you will touch, sir, to make the camera
See,
clear?
you want to clean it, right? So this area is like a gutter where all the garbage is flowing. So you want to clean, so you will go and clean it in gutter. How the camera will become clean? Yes. So search for the clean surface.
Omentum?
Okay. Omentum, here liver, we have not gone only. So this is clean structure. So it will wipe off your blood. Okay.
So what
now you have come back.
This is very hot. This will sometimes, if you keep inside for a long time, this light will damage.
When it is attached to a telescope, it can never damage. Okay, because there are some lenses which will dampen the light effect, which will dampen the thermal effect. Hand up. Chala. Just. For you, descending cervical is like your enemy. हाथों बाजू करना पूरा. Fire.
Sir, while using firing here, whether we have to do bipolar or we have to do use sealer, sir.
Sealer.
And this is having two options.
Always. There is no
Sealer.
bipolar. Sealing only.
Because this shearer will have three options. Cut. First one is seal. Second is cut. Third is coagulate.
Yeah. So that coag is not for you. It is for unipolar.
Okay.
Okay. So when you are using bipolar, there are only two options, not three options.
Okay.
Either it is seal or either it is cut. That's all. When you are using unipolar, again, you have only two options, not three options.
Can I use now coagulate and show you, sir? It is also coagulate.
What do you want to
Can you touch, sir, once?
Acha, okay.
I am using now coagulate. It is not
What
doing its job.
What you are?
This one.
That coagulation will work for unipolar, not
That
for
only, sir.
bipolar.
This bipolar, it will not work.
No, where it is working? Through fire?
But it worked for my madam, sir.
Which
HOD
work for a madam?
Yes, sir. HOD madam will use coagulate option, sir.
I'll ask him this instrument whether does the instrument has brain, because I am holding, so not working. Okay, so I am just making your colpotomy area avascular. So that when you come with your unipolar, these are all the culprits.
Yes.
Okay.
Which you are scared of, worried.
Not scared of, but again and again, it will spoil your vision.
Yes.
Okay?
No.
Go ahead. Entire length of instrument, no. You can see this black. Okay, that is insulation. Yeah, that is insulation. About here.
Okay. So we should not get panic when some vessel is spurting. So we
you are telling it to yourself or people?
No, sir. I am asking you.
Hold on. Why? See, if you become panicky, it is not going to solve the problem. No? Okay, identify the problem where it is oozing. Okay. If your nature is to become anxious, take deep breath. Okay, stop for 2 minutes. Okay. Take deep breath, identify, it is oozing here now. Okay. That is only the solution of anxiety.
Okay.
Okay.
Okay, sir. So we have to take deep breath.
Above, see the light. 1 second. Rotate. हाथ नीचे कर.
Sir, with the tip or with this one base also we can do, sir?
So now you were asking for the last, no? Now
last.
we will see whether my hand has brain or not. We'll see. Okay, press that last button. Ayo, it's working.
You said with monopolar it will work.
So that's what I wanted to show. This is monopolar. So in monopolar it will work.
Okay,
For bipolar it won't work.
Okay.
Go ahead. This. 1 second.
So accidentally if we go behind, sir, posteriorly, below the uterosacral, so not the rectum, so nothing will happen, sir?
you will shorten the vagina, and her husband will come and complain that madam has operated for hysterectomy and has shortened the vaginal length now. Apart from that, nothing will happen.
Okay, sir.
Right now, it's only vagina.
Okay, sir.
1 second. Okay, unchu. Convert the machine. No?
So no need to hold the tissue, just by opening the jaws also we can do, sir.
Yeah, this is something like surface coagulation. So how you can make use of this instrument everywhere? Fire. Stop. Hand up. Fire. Hand down.
In this case, the carbon dioxide volume what is showing is 191 liters, sir. But
you have not used.
We have not used.
So that is a blast case. Convert the machine. So what happens is once you switch it on.
That whole volume is it will be this case or
no, total. So if you had switch off the machine, okay. If you had switch off the machine, then it will start again from zero. If you had not switched off the machine, it will show you additive, both first and second both. So total machine has pumped. Unipolar, you people have become pakka. I remember first time you
were training.
See, if you get, you only told me, no, first time, hey, sir, is there any other option with unipolar? If you know this instrument, how to use, this is the fastest. Go ahead. Who will cut like this? Which instrument will cut like this? And you know the cost of this instrument? Approximately?
1,000.
Anyone?
1,000?
700 rupees instrument. Okay. And
so which is your favorite?
Not like Shearer.
Sir,
Shearer is my favorite. Anytime.
Sir, many of them ask, sir, how to insert manipulator. Can we show them, sir?
Now uterus is gone. Before you.
That only, sir. But now we'll show. Just we'll tell them to that we'll hold like that.
I'll tell the exact procedure. Okay. Because here now uterus is out, nothing you can do. So I'll tell you how exactly. Okay. So put a Sims. First put Sims. Hold anterior lip. Okay. Now take out the manipulation. Savlon. Vicry level. Shinu, camera pe.
Camera. So it contains rod, and this is. So all these are detachable.
पकड़ना पहले पकड़ के दे. I showed it that instrument how it works, that I already told you. Now how to insert it? Put Sims. Okay, this rod goes inside this colpodomizer. Okay, now you are sitting like a vaginal manipulation side. Okay, so Sims, hold the anterior lip. Now this you keep it here. Imagine that this is your uterine sound. Okay, hold the anterior lip. This, let it go inside the uterus. Once this goes inside the uterus like a uterine sound, okay, keep it steady. And then you introduce this thing. Okay, this part goes inside vagina. Okay, so that this part will come at the fornicial level. Okay. First one, madam. The same what I told, no? The cervix should come if it is uterus. You are putting this thing inside uterus. This is cervix. This is cervix. Okay, so cervix will come like this. Okay, and when you are pushing like this, cervix will be smugly fitted inside this. Right, and this will lie on the fornicial level. Now this is 3D imagination.
Cervix is hypertrophic.
Yeah, so if the size is more, cervical size is, let's say, more. Okay, so if it is more, this won't be lying on the fornix. This will be lying on cervix. So you will be cutting cervix, right?
So this is the specimen, uterus with this also fibroid. So lateral wall fibroid.
There are three sizes, three cup sizes will come when you purchase the new one: small, medium, large. Okay,
So
depending
this
on the
is,
size of cervix, this is medium one.
so for example, this is the uterus and cervix. So what we'll do is, so we'll take the instrument like this. Then we'll keep inside with the help of sim speculum, as sir said. So anterior and posterior lips are held. Then we have to introduce this rod into the uterus. Then after introducing into the uterus, we have to push this. No, fine. After introducing into the uterus, what we'll do is, as sir said, we'll push this rod into the uterus. So the center rod, it will be available in 3 sizes. This will be available in 3 sizes, which will be given along with the manipulator. So depending upon the cervix size, so it will have small, medium and large. So depending upon the cervix, for example, it is hypertrophied, we can use bigger one. If it is small, like postmenopausal women, you can use smaller one. But the funda is, so the entire cervix should fit into this. So when entire cervix gets fit into this, then only we will be able to see the colpotomy area clearly, and that is a place where we have to be, like sir said, no. So that is our target. So like this we have to use, because everybody asked about this, so we are demonstrating this. So we'll give the contact number. So sir will, there is a courier facility for this. So even our hospital also, we bought this from sir. So if anybody will, at the end of the session, anybody is interested, they can contact us. We'll give the number. As sir said, sir is having Kimea surgicals, and sir will provide us shearer machine, actually shearer. So they'll give red one with this red color shearer, gold color shearer, white color. So this is gold color. So this is the shearer instrument. Okay, the shearer instrument, it is gold color. So the this one tip of the instrument is gold in color, and this is little, like what I feel is, this is little dramatic, the instrument. Okay, so what sir has designed.
Go inside.
So this is the shearer. So we bought this from sir when we went for training. So sir has showed this one to us. So it is, even if you can feel, so this is looks little atraumatic, and we can grasp the tissue, and so it will help this purpose, like it will not just crush the tissue. So we felt like that. So we bought this hand instrument.
In India, I'll come to that thing. In India, there are multiple surgical shops, okay, who will be selling you shearers starting from 4,000. It will go till 20,000. Okay, so you can, even in Tirupati also, even if you go to any surgical shop and ask for shearer, they'll give you this thing. Okay, but that depends. There are so many quality factors are there. Okay, so now because this thing is in demand, okay, people have started manufacturing, but there is no harm in using any shearer. Okay, I have designed my own. Okay, that is the one what you, maybe I think since 2 days we are using that only. So the shearer what you saw, that is designed by me. Okay, rest any surgical shop you will get so many similar like that. Okay, maybe what modifications I have done that you might not get, but shearer is same.
So in this, if you can see, it is designed by Dr. Juhul Patil sir. It is written here on the instrument. So which is with silver one tip. So what we get from the Allen. So electrosurgical unit, what we are using is Allen in our hospital, and camera set, everyone we are using Stodds. So camera, monitor, and endoflator. So we are using everything Stodds company, whereas Allen we are using electrosurgical unit. Allen we are using in our hospital.
Suction irrigation ready.
So as sir said to us, so if everything is it's like a laparoscopy means, so all machines should also work properly. So for example, as you have seen, there is suddenly camera, if it is disturbing or something, monitor is not working, so we can't do the work properly. So all setup should be proper so that we can perform the laparoscopy in time.
See, it is all about machines. Okay, this surgery, it's everything is to machine. Okay, because if machine, your hands are working, but machine stops functioning, how will you perform surgery? Right. So the only difference between this and open surgery is you don't have your hand free. So even if you are excellent surgeon, but if your machine doesn't reciprocate to you, okay, then what? Nothing. You cannot. Okay, so that's why what madam is trying to tell is, before you enter the OT, see your machines. Okay, understand like what machines you are using, and if you are ever interested in pursuing like becoming a surgeon, lab surgeon, okay, or anything, so I feel like you should be very choosy. Okay, you should be very choosy with your machines. And all the machines, my belief is we should keep it with us only. We should not be dependent on the hospitals. If you give me the machine, then only I'll operate. Array, they will never give and you will never operate. Nowadays, buying a phone of 1 lakh, 1.5 lakhs, okay, people doesn't think that much. But when it comes to good cautery machine, good camera, okay, suddenly everyone like, why we should spend that much?
Sir, shall I tell about the amount, sir? You are
Which amount?
like 6 you said, no sir? Is it fine? Can I tell?
Which one?
Without electrosurgical unit. You said 6.
Yeah, that is my own.
Yes sir, that only can I tell?
Yeah. That is my own company, so you can
tell. So what we actually, when we went for training, so I want to share with all of our delegates and faculty. So when we went for training, so sir was like, it was like a suitcase. So 3-4 suitcases they are carrying. So that brother, Ravi brother and one more Pradeep brother. So we went for nearly 4-5, around 6 to 7 hospitals we went. We travelled a long way. So but that suitcases they are carrying and they are opening and just they are within 5-10 minutes they are keeping there and it is everything is ready. So we asked sir, we liked it very much, how much it costs. So actually, for example, stars and all, if you want to buy, it will cost around 40 lakhs. So sir said it is only 6 lakhs without electrosurgical unit.
No, so what she is trying to tell is, I have designed a camera. Okay, so it is my own design and we have designed a camera and I have made it very cheap. Okay, because there are so many factors, ma'am, no need to go into all these things, but I'll tell you only one thing, that it is cheap. Okay, and you won't find any difficulty in performing cases. Okay, so even if your initial days where money is the problem, okay, at that time you can definitely go ahead in buying the my camera. So that is also good enough. Okay, so your journey, because this stores and all German cameras, okay, that 40 lakhs and all, until unless you are like doing it in multi-speciality, they only can afford. No common people.
Sir, there you are doing now, sir, now.
Yeah.
There external iliac will not be there.
No, not you. You continue.
External iliac will not be there.
External iliac will be there, but see, I always tell, like arteries are like males. Okay, and veins are like females. So I'll give you why I tell like that. So if you go nearby vein, no, you can puncture them easily. Okay, how women mentality is. You can puncture them easily. Once you puncture a vein, okay, it will ooze slowly. Okay, how you are getting angry on your husband? Slowly. Okay, but in that slow thing, it will spoil the entire field. That's how women do, I think. Okay, this side. Whereas, and it is difficult to control them, veins, because it is difficult to control the bleeding by veins. Why? Because of the thin walled nature of the veins. Okay, you cannot form a proper good coagulum with vein, right? Whereas arteries are like males. You cannot puncture them easily. Okay, you have to be rough to puncture an artery. Okay, veins easily. Okay, because of thin wall. Artery, because of thick wall nature, you cannot puncture them easily. But once you puncture them, okay, it will ooze torrentially. Okay, but it won't spoil the field. But it is easy to control them. That's how I like our meal. Okay, because the funda is because artery wall are thicker and vein walls are thinner. Okay, but the analogy is like this.
Sir, out of subject, just we want to know, sir, about your family.
My family?
Yeah.
They are more than happy in Hyderabad, ma'am. And
no, what is ma'am? What is your?
No, my wife is Gaini, ma'am, and she is from this place only. Okay, Tirupati only. Her mom's native is from Madanpalli. Okay. So, I have a center in Hyderabad. Okay. So, what else? I have a daughter. Irrigate.
As you are doing endosuturing, sir, we are clearly seeing the small vessels and all. So what we'll do in our setup is we'll do suturing from this.
मेरा क्या कर रहा है श्रीनु? क्या हो गया इधर? हाँ, ma'am.
So as you are doing endosuturing, sir,
ma'am.
So we are clearly seeing, sir, that lateral levator.
Puppy उसको. Kiss the sigmoid. ऊपर रहना, ये कौन सा तरीका है दिखाना है ऐसा? Sorry, you come back again. As I am suturing.
Yes, sir.
You can see clearly the capillaries.
Yeah, sir. Endosuturing we are able to see, sir. When we are doing from vaginal side, sir. So again, when we put port and when you are seeing now, everything is getting puckered. Everything is getting
puckered. When you are doing it from down, entire edges will get inverted.
Puckered, yes.
No, puckered means it goes inside.
Inside.
So I think yesterday's case we saw, where I was that side, I had to come this side because that lower segment you were there. I don't know. So someone did suturing from below, no, vagina. The same case we had to open it out. You were not there.
Not there.
So some of your residents, okay, so they sutured it from below. Okay, edges were inverted.
Yeah. Then what we have to do, sir?
Again, the same thing. You have to make sure before going for suturing, okay, make sure that your this thing is avascular before only, not after suturing. Here I have a luxury of doing this, that's why I am like doing it later.
Yes.
Okay, but you before only. Okay. Before proceeding from below, make sure that everything is avascular.
Or learn endosuturing.
Not or. Obviously, you have to learn. Okay, the thing is, but in initial days, avoid it. Okay, so gain some confidence in doing the case. Till that time, keep practicing. क्या? छोड़. Sakshana.
When we are doing a, sir, every time bowel will disturb us, sir. Now bowel is disturbing. From yesterday
Lock the position in your brain. Okay, head low, right tilt. छोड़ दे, निकालो.
Silver. Scissors.
Fire, no? Fire bipolar. Fire. Yeah, no.
This also, sir, with shoe and chappal, we are not feeling that. Even driving also.
Hey,
sir,
that is your.
That is our.
That is your XX deficiency.
XX
not XY cannot do anything.
No, sir. Just.
Okay, even my wife drives. Okay, after removing the chappal. So that nothing I can do. Make a habit. What is that? Go ahead. Fire. Fire continues.
See, sir, this area we are worried.
What worried?
Where is ureter? Where is external iliac?
This is external iliac. This one. It goes outside. Okay. I am where? I am
Because you are
above.
placing your base on
Here.
like this. Onto the
So on artery, if this is an artery, if I fire like this, no, nothing will happen. Vein, vein will get punctured.
Like
Vein, like woman. If you do this thing, like flicking to a man will say, okay. Female, why did you do? Chalo, we had an excellent session.
Sir, thank you, sir.
Thank you so much.
Thank you very much, sir. Thank you.
Thank you.
Sir, we asked you so many doubts with lot of patience. You cleared almost all our doubts. So I have asked from basics the very I think some insensible questions also, I think. So but you answered each and every question, sir, with lot of patience. That too while doing surgery. Thank you very much, sir. Thank you is a very small word from our side. I don't know how to express. I think all of us are feeling, sir. I'm talking in behind from there.
And you all are lucky to have Bhumna ma'am because she is the person who accumulated this type of cases. Yesterday only what we were discussing, this is not a project of Eagle. Okay, this Foxy, Eagle, this project is like very small cases. Yesterday what you saw, that is like proper laparoscopic conference cases. Okay, like that she accumulated so that you can have at least an idea. Okay, so where market is going. Okay, here continuously PIH, GDM. Okay, but once you come out of the market, okay, the market is going where? So it is a very good thing, at least like she accumulated this type of cases in one day so that we all were in one place so that like we could have explored each and every. I think we explored all the pararectal spaces, Retzia spaces. Coming to fibroid, we had fibroid, adenomyomectomy, fibroid to another level. Okay, morning, hemoglobin also fell down, then suddenly it came back normal. Very nice exposure and keep learning and
Sir,
start doing.
Because of an HOD ma'am.
We are always there. Madam is
because
always
of you
there.
and all our faculty, everybody, sir, each and everyone, anesthesia team and workers, ground level workers, brothers and audiovisual, each and everybody.
No, those two,
my
anesthesia team,
postgraduates.
Thank you.
Thank you.
Thank you.
No.
Everything.
Sir, 1 second, sir. We'll call anesthesia, madam, sir. Brother, anesthesia. పైకి వస్తారు అది ఎక్కడ అనిస్తేషియా పిలవండి అనిస్తేషియా సార్ పిలవరు ఒక్కసారి కుమార్ సార్ ఎవరుంటే వాళ్ళు పిలవరు సార్ థ్యాంక్స్ రాజశేఖర్ sir is anesthetist today, sir. I think Sunday other two sirs like Professor Jeevan sir and
I met them. Thank you so much, sir. It was excellent effort by them also. There was no wastage of single minute, I think. Okay, every time everything was ready, and at the same time the energy what your resident had, what madam and youth already have, because of this thing we were able to pull off at least like by 4 o'clock we had finished 16 cases. That's not a like small number, and doing the cases like yesterday what we did, that cannot be done in one day, but still we pulled it like off because of this guys, because everything was ready. Okay,
thank
so
you,
thank you so
thank
much,
you everyone.
Thank you.
Sir, one photo, sir. We want one photo here, sir. For APMC they are asking one photo in scrub. Already photo తీసుకుంటున్నారు. Your sir. That inside one photo they are asking. ఒకటి తీసేసుకున్నాను, ఆల్రెడీ తీసుకుంటున్నారు కదా. HOD ma'am పిలవండి. HOD madam వెళ్ళిపోయారా సార్? జిమ్ సార్, జిమ్ sorry.
Close your okay, okay.
Operating service was brilliant, live surgical demonstration. Your expertise and dedication made this session truly informative and inspiring. Thank you so much. We sincerely appreciate you for continuous encouragement, dedication, and minimally invasive gynecology is truly inspiring. Thank you for your support, leadership, and presence, students. Congratulations to the Operating Committee for the excellent coordination and successful conduct of this TV program. Your hard work and team is truly commendable. Congratulations to the anesthesia team for their support for education. Congratulations to the OT staff members, each and everyone who helped in the OT, nursing staff, anesthesia technicians, and audio visual teams who made this CME workshop successful. Thanks to every postgraduate student for making this laparoscopic workshop very successful. We invite our HOD ma'am, Premila ma'am, to speak some words about this laparoscopic workshop.
Good evening all. It's my privilege to be here as a part of this prestigious program with the national faculty. Especially I am very grateful to the Zoom party sir. All of a sudden they came for this one. We invited sir nominally, but they have accepted heartfully and worked hard with their colleagues. They came here and sir did so many difficult cases in a span of 2 days. They did 16 cases, not a difficult, easy matter. Yesterday they did about 10 o'clock, 10 to 10:30. How hard it is. Since morning 10 o'clock to night 10 p.m. Very hard. Even though by morning 10 o'clock we started the session. We are very grateful to sir. Especially it's a boon for all our students. Get involved in this session and heartfully they learned. You learned or not? Huh? Especially in the end of the session, they came vigorously compared to yesterday. Very grateful, sir. Thank you so much. We are grateful to all the organizing teams who have participated in this. Each and every faculty, including the PDs, fourth class, half class, teachers, anesthetists, all the things and everything. Everybody, even though it's a Sunday, they have participated actively. We are very grateful to all the faculty, all the staff. Thank you. Sir, Zoom party, sir. A small gift, sir.
It's not people about to be Thank you, sir, for your life demonstration.
Engaged laparoscopy surgeon, almost a year my son age.
Thank you very much, sir. Thank you. Now we invite Ankusha, sir. Please accept our Now we invite Sandeep sir to answer the small gift, sir. Now we invite Chintan sir to answer the small gift.
Operate anesthesia for all except June 47 is going to give anesthesia. Sir.
Now we invite Ravi brother and Sindhu brother to accept small gifts from us. Ravi brother. Ravi brother is excellent in showing. I request Jubil Patel sir to speak some words about this laparoscopic workshop.
So hi everyone. Rather than wasting more time, I directly come from the conclusion. How was the course? Whether like everyone is satisfied? Okay, it was the effort. It was mainly the effort by man. Okay, so like how I told you yesterday, like how she brought all of us together and adding to all these things, like accumulating all these cases at one place, it's not a joke. Okay, at the same time, Madam was standing from morning to evening with us, that is also not a joke. And I'm very thankful to Muna ma'am, okay, arranging all these cases, and after going from here also, I know my job is done, okay, but your job is not done till the time patient goes home, right? So because of that things, okay, that requires encouragement, that requires support from seniors, and that requires support from PG residents, okay, like you people. Until and unless you show that enthusiasm, they don't like to accumulate. They don't like to do something for you. But in medical college, to run some program like this, okay, it's not a cakewalk, and they did it. Okay, and I can guarantee to ma'am, like in entire India, okay, because in Andhra, Telangana, Uttar Kannada, I am only the chief coordinator this side. Okay, so wherever we go, but in entire India, we have not seen accumulation of this variety of cases, okay, to be operated by us within 2 days, and at the same time, there is not even a single lapse of second in between. So kudos to anesthesia team, kudos to your team, ma'am, and Rina ma'am, Sonia ma'am, everything was to the level that what we cannot even imagine. So even if we, let's say, madam, we were discussing yesterday, so even if when we conduct a workshop in like some multi-specialty like Yashoda, Apollo, okay, there also we operate maximum 4 to 5 cases a day, okay, where we have crossed that limit yesterday like double. We operated 10 cases, and adding to that, it is not like simple, straightforward PLHs, okay, simple, straightforward cystectomies, simple, straightforward tubal ligations. As you like saw yesterday, okay, fibroid also has limits. Okay, madam crossed that limits in giving me fibroid. Okay, adenomyosis, there is a limit. Okay, madam crossed in that also to give me. I think the most easy case yesterday I operated was that pectobexima. Apart from that, everything, and that is very good effort. What I'm trying to say is, like in medical colleges, when you are learning residency, even if you don't get a chance to do, but even if you get a chance to observe, okay, that is also more than enough. Okay, so that once you go from here, at least when you come into the market, okay, you won't be completely new. As I was like discussing in the OT, okay, like most of the residency, you will be discussing about PI, GDM, right? But once you come into the market, you will see there are so many other fields which has come in the market, like cosmetic gynecology, okay, like lab. Okay, so suddenly in medical college, you become expert in doing open surgeries. You become rough in handling the tissues. But when you come out in the market, that finesse you need to show, okay, to prove your point. Okay, that finesse, even if you don't know how to show, but at least now you know how the surgery should be done. Okay, even if you don't know how to perform the surgery, okay, but knowing that thing that it should be done in this way, that is also more than enough. And I think in this 2 days only, after like showcasing at least 16 cases, I think most of the residents who were there in OT, I felt like more than happy for them.
Okay, what Madam and Duna Madam what they have arranged. So I think I'll finish my this thing, and I think all the best for you. Keep learning, okay, and keep attaching to the good teachers, okay, who can support you in every sense. And I feel like again and again, finally I conclude telling you that you are in excellent hands, where HOD is putting up so much effort, okay, in teaching the PG students. In government, to take my word, in government medical college, no head of department will put this much effort for a PG to learn. Okay, so be happy and at the same time keep learning with Madam. Okay, with Madam, our venture has just started, but we will keep on exploring. Thank you, Ma'am.
Thank you, sir. Thank you, sir, very much for your beautiful speech. Next, I invite APMC observer Sindha ma'am to speak some words about this section.
Good evening, all of you. I congratulate the Department of OPG and all the organizing committee members who worked hard, I think maybe for the past 2 weeks for the conduct of this program, and it went on well, very much, and I congratulate you one and all the team coming from all over India. Thank you.
Thank you, ma'am. Thank you, ma'am, for your valuable speech. Next time, I will invite Bharti ma'am to speak about the laparoscopic function.
Good evening to all my team and my family. Actually, this was my dream that in the government college, all the students with enough MSc BScs, all the postgraduates should have to learn. Actually, obstetrics, they are very much involved and also they are very much welcome when they go out of these things too. Like that, even in gynecology and in this minimally invasive surgery also, you should be thorough. And you should not go out and pay money and then learn. I wish all the postgraduates to learn minimum diagnostic lab and is thoroughly, and you have to go to the other stage also. For this, you have to show your gratitude to all your teachers. I thank and I wish that Pramila, Uneswara and all the team members and all the faculty also to train and teach the students in the same way. So tomorrow, you will get pride whenever or wherever you go. You say, my teacher. It's a very good gratitude. Thank you very much.
I would like Anna ma'am to share. Thank you very much. It's very excellent question. All of our targets are very lucky. Thank you very much. Thanks to all. Coming to this organization, she's very busy now. She's busy. Madam, so don't mind if I miss any names. So basically, I think madam, she has just feedback that it's always well. So from each and everyone, from the bottom up, from HOD ma'am, and we thank each and everyone on behalf of ma'am. I'm telling this, and even the nursing staff, anesthesia team, everybody. Thank you very much.